Good morning, everyone. Good morning. We are going to start with the session. Yesterday, we discussed the present of CBME. Today, we are going to talk about some of the future interventions which need to be incorporated in our system. Mentorship is considered a very important part to guide the learning trajectory of the students. Let's listen to some of the modalities which can help us to make most of mentorship and look at the CBME with a growth mindset. And the chairpersons for this session are Dr. Chetna Desai, Professor and Head, Pharmacology, BJ Medical College, Ahmedabad. Ma'am is CMC FAMA 2007 and a resource person, FAMA Regional Institute. Please, ma'am. We also welcome the other chairperson, Dr. Anil Kapoor, Professor of Medicine, People's Medical College, Bhopal. Please, sir. I request the chairpersons to kindly introduce our speaker, Dr. Beck.
Thank you, and thanks organizers for giving me this opportunity. And it's my privilege to introduce the speaker for this session, Beth Ann Cummings. She's Assistant Dean, Health Professions Education at McGill University, Faculty of Medicine and Health Sciences, McGill University, Canada. She has been the former Associate Dean, Undergraduate Medical Education at McGill University, the Chair, General Internal Medicine Examination Board, Royal College of Physicians and Surgeons of Canada, and member Medical Council of Canada, Assessment Information Task Force. Faculty Honor List for Excellence, Educational Excellence 2016 at McGill University, and the Canadian Association of Medical Educators Certificate of Merit 2012. These are major achievements. Welcome, and we look forward to hearing from you.
Thank you, ma'am.
NCHPE 30
So there is some problem with the
recording नहीं है यहाँ पे ये है तो ये बेहतर
दो
और एक पीपीटी दोनों पीपीटी है
पीपीटी तो चलानी है
ये पीपीटी जो बोलेगा वो ना
हाँ रिकॉर्डिंग तो चलानी है
ये है ना बेहतर ये ऊपर
सर वर्ड में
ये पीडीएफ तो थोड़ा 30 एक दिन पहले क्यों नहीं देख सकते यार ये सब
Good day, everyone, and thank you for including me in your National Conference on Health Professions Education. My name is Beth Cummings, and I work in Montreal in Canada at the Faculty of Medicine and Health Sciences of McGill University. There, I have the pleasure of being the Assistant Dean, Health Professions Education, an associate professor in the Department of Medicine with a clinical practice in general internal medicine, and an associate member of our Institute of Health Sciences Education. I'm going to be speaking with you today about mentoring and the growth trajectory in CBME. Of course, I wish I could be with you in person, presenting this live and having the opportunity to interact with you directly during a question and answer period. Given the circumstances, though, I'm very much looking forward to receiving any questions and comments you might have electronically after the end of the session. In our conversation today about mentoring and the growth trajectory in competency-based medical education, I hope to share with you a little bit of our lived experience and the theoretical foundations for competency-based education. I have no specific conflicts of interest to declare with regard to my participation in this conference or this specific presentation. The learning objectives for this session are to understand the learning trajectory in competency-based medical education, to understand the role of faculty in CBME as teachers, coaches, and mentors, and to consider the structures and processes that support teachers in guiding learners and learning in competency-based medical education. Medical education used to be referred to as steeping tea, and I'm sure that many of you will have previously heard this analogy. Let's talk about this and delve into this analogy a little bit further and why it's fallen out of favor. The concept of steeping tea and paralleling this with medical education is that to transform a layperson who's been admitted to a medical college and is thus a medical student into a doctor, what's required is time and the right tools and ingredients. This notion implies that with sufficient time and the right tools, any person could, in essence, become a doctor. This is not quite as simple in actual practice. As is indicated on the website of one of my favorite local tea companies that's Canadian-based in Montreal, David's Tea, making tea is not actually as simple as just boiling water and pouring it over tea leaves or a bag of tea. In fact, there are things that we commonly refer to as tea in everyday language that are actually herbal and don't actually contain any tea leaves whatsoever. Even within the realm of tea, there's multiple types of tea, of course, including white tea, red tea, green tea, black tea, oolong, and chai, amongst others. Each type of tea requires different consideration and different care. The water needs to be prepared to a different temperature. The amount of time that the water and tea have to sit together to make the perfect cup also varies by type of tea. And whether or not you need to add other ingredients for the tea to reach its full potential and for us to benefit the most from its flavor also varies by the type of tea. Some teas, for example, are commonly enjoyed with milk added. Others, one might not add milk, but might add sweetener, and to some, you might add both. Making tea is therefore much more complicated than the initial analogy would seem to suggest. If one applies that idea to medical education, you can get the idea that different learners have different needs, and with a more elaborate understanding of the tea analogy, one might think it could still be appropriate to medical education. However, there's a fundamental problem with thinking about medical education as steeping tea. Indeed, this relates to the lack of agency of the learner in that analogy and in that model. The learner doesn't have the agency to decide their path or to become the type of T that they'd like to be. In fact, the learner is simply subject to the medical education, in other words, the tools and ingredients that we choose to provide in order to end up with a doctor at the end. This is quite contrary to our modern understanding of medical education and the importance of the learner's direct engagement in deciding what and how to learn and being an active participant in building their knowledge. The learning trajectory in any profession, including medical education, begins with someone at the level of a novice, and the educational journey is one towards expertise with the goal of becoming an expert. We used to speak of expertise being attained at graduation, and that we'd like to test for expertise on licensing examinations or exit examinations. Although this model is a better understanding than the idea of T, in the sense that it shows a trajectory and it shows that there are time points along this trajectory, it's still incomplete. I would posit that a better way to look at medical education in the competency-based medical education era is to think of the learning trajectory as the learner building a bridge as they journey between being a novice towards expertise. When a learner begins their undergraduate medical education experience on admission to a medical college or medical program, they don't start right at the very beginning of the bridge, because although they're a novice in medical education and in the expertise of becoming a doctor, they do have certain building blocks from their prior experiences, their prior education, and some of their traits and learned attributes over time that already have started them along this pathway. Undergraduate medical education furthers their journey from novice towards expert, which culminates in a degree which is an MBBS in many countries and an MD degree in others. Following this, there's a graduate education pathway, which in countries such as Canada is referred to as postgraduate medical education or residency training. There may be a higher degree awarded at that time or a certificate of completion. Following this end of formal training, individuals embark on the lifelong learning that continues in continuing professional development, which is sometimes referred to as continuing medical education. Of course, as teachers, this lifelong learning also includes faculty development and may also include furthering our abilities as scholars and researchers. Thinking about the model in this way, the novice has some responsibility for their educational journey because although the overall trajectory is clear, the learner still needs to decide what to learn at what time and precisely what individual path they're going to take within this broader framework. The learner also has to develop the skills to enable the lifelong learning that will become required in order for them to be successful in their career and as a clinician. It's also important to note that you can think of expertise as being both a destination and a journey in this model. Of course, after completing our training and being in practice for some time in our careers, we are often viewed as experts by colleagues and indeed by our students and our patients. Nonetheless, the notion of expertise tends to shift and change over time as our understanding of medical education, health professions education in a broader sense, clinical medicine, and biomedical science also continues to evolve. Thus, part of the importance of engaging the learner in the competency-based medical education learning trajectory is that it prepares them for the need for this lifelong learning, where they have to continue to take responsibility for identifying learning needs and setting out to fulfill them, knowing that expertise will always be just one step out of reach. Now that we've spoken a bit about this idea of the learner building a bridge from novice to expert, Let's build on this metaphor a bit more as we delve deeper into teaching and learning in competency-based medical education. The Canadian Competency Framework for Medical Education is commonly referred to as CanMEDS. This framework was established by the Royal College of Physicians and Surgeons of Canada. This flower, as depicted here, has medical expertise at its core, in particular because medical expertise is what distinguishes physicians and surgeons from other health professionals, and indeed professionals outside of the health professions as well. The competencies around the medical expert are just as important and essential to the practice of medicine, but may also occur and overlap with other health professions and indeed other professions in general. These competencies include professional, communicator, collaborator, leader, health advocate, and scholar. By thinking of this competency framework, learning objectives in postgraduate medical education or graduate medical education are framed in these competency-based terms and fit in within this framework. Similarly, the requirements for continuing professional development, sometimes referred to as continuing medical education, also follow this CanMEDS framework because the maintenance of competence program is actually run by the Royal College of Physicians and Surgeons in Canada, though some of the licensing bodies in the individual provinces in the country also have maintenance of competence requirements. And this Canadian competency framework of the CanMEDS roles is also often used to frame learning objectives in undergraduate medical education, even though the Royal College doesn't have direct responsibility for this phase of education. This allows the medical education system to be aligned, where we think about the competencies beginning to develop in undergraduate medical education and then progressing through graduate education and onward through lifelong learning. Although what is expected of the learners and indeed the professionals at different stages is different in each of these competency spheres. What is the role of the learner in this type of competency framework? Well, it's important to note that the learner is expected to build their own bridge from novice to expert. They do this through longitudinal learning and development of competencies. Of course, they benefit from formal learning as part of educational programs in the classroom, in the simulation center, and of course, through assessments. They also have the opportunity to participate in experiential learning, which often includes participation in patient care or learning at the bedside. In order to build their bridge, the learner has a deep responsibility. It's important for them to understand what building blocks they need for their bridge. What are the experiences that they need to make sure that they have? How do they need to engage with those experiences to get the most out of them? How do they get the kind of feedback and guidance that they need to continue on their learning trajectory? And how do they ensure their safety and the safety of their patients as they progress and build their bridge? Kolb's cycle of experiential learning is particularly helpful to understand the learner activities during the experiential learning activities, including clinical medicine, though reflective learners can also apply this to simulation and other types of learning activities. Kolb's cycle of experiential learning begins with a concrete experience, which is followed by reflective observation, then abstract conceptualization, followed by active experimentation. And then the cycle begins anew with a different concrete experience. Said in different terms, the learner starts by doing something. Then they think about what they've done. They draw conclusions about what that means to their learning and as they build on their experiences. Then they adapt and they think about what behaviors, skills, attitudes, and knowledge they need to continue to build, or what they need to do differently, what they need to think about differently, and what they need to practice in order to continue on their learning trajectory. And then they begin with a new experience and do things once again. And the cycle continues. In a system where the learners are so empowered, the role of the teacher also changes. The role of the teacher in competency-based medical education is largely about supporting the learners while they build their bridges as they transit from novice towards expertise. To do this, the teachers have to provide scaffolding, and they remain as a safety cord throughout the learner's trajectory. This, of course, is complicated enough with a single learner, but many teachers are faced with multiple learners, sometimes all at once and sometimes sequentially. This requires the teacher to develop a sense and a knowledge of each learner. What does that learner need in order to build their bridge? What tools and materials do they require? What kind of support and encouragement or guidance do they need? Where are they in their trajectory? And they need to be able to provide, as teachers, different scaffolding to different learners, but also different scaffolding to the same learner for different competencies and different scaffolding to the same learner over time. The idea of the teacher remaining as a safety cord speaks to the importance of ensuring that the learner is safe throughout their learning trajectory and is allowed to fail, have challenges, and receive feedback in a safe environment, and also that patient safety is never compromised in cases where the learning takes place through participation in patient care. If we again think about Kolb's cycle of experiential learning that we just discussed with regard to learner activities, we can now superimpose teacher activities on this thinking. While the learner is doing things as part of their concrete experience, the teacher participates in observation. While the learner is thinking and reflecting on their experiences, the teacher can support this by providing feedback. As the learner is drawing conclusions and working through abstract conceptualization, the teacher can help guide this process. During the active experimentation phase, when the learner is planning their adaptations, the teacher, can support this. This cycle, again, begins anew for the learner and may begin anew for the same teacher, or the learner may engage in this cycle repetitively, but with different teachers engaging in the cycle a single time, depending on the way the educational model is structured. When you have the opportunity to work with an individual learner for a specific skill or task-based, you may actually change your role slightly from being a teacher to being a coach. Coaching is the process where an experienced member, usually of faculty, supports a less experienced member, in this case, a medical student or graduate trainee, in achieving a specific goal by providing training and guidance. This coaching is often skills or task-based. In other words, as a coach, the teacher is helping the learner fill in a very targeted or specific piece of their educational puzzle. This is in contrast and somewhat different to mentorship. Mentorship is a dyadic longitudinal relationship, again between a more senior, often faculty member, and a more junior, often learner. The process of mentorship is about helping the mentee achieve their goals, which can be instrumental, psychosocial, and also sponsorship. In particular, the goals, of course, relate to learning, relate to socializing into a new group, finding balance, and developing as a person, and developing as a professional. This can relate to the notion of professional identity formation and understanding what the profession is and how one fits, but can also relate to having opportunities for professional growth and career advancement. Mentorship may involve coaching and may involve helping a learner fill in a specific piece of their educational puzzle, but often addresses topics that are a little bit deeper and require more of a longitudinal connection, such as work-life balance, interpersonal issues, career growth, and career opportunities. Mentorship, unlike coaching, which can sometimes occur once and not have an ongoing relationship, requires an ongoing commitment on the part of both the mentor and the mentee and requires trust between them. When mentorship is done well, it benefits the mentee, of course, but also can have significant benefits for the mentor and the institution. So where does assessment fit when we're talking about the mentor being so focused on the learner and the mentee's goals? As you can imagine, the focus of the educational program is going to be on curriculum requirements, which often relate to societal needs, may relate to accreditation requirements, national standards, and other external factors, as well as the mission, vision, and values of the medical college. The mentor's focus, on the other hand, is primarily on the learner's goals, though it's operating within the framework of the program's focus when the mentor has an educational role. This can create a bit of disequilibrium, especially when it comes to thinking about assessment and how the mentor may or may not play a role in that process. What's very important in a competency-based medical education model, and what allows mentors to at once participate in guiding the learner and assessment moments, is the concept of the growth mindset, which underpins all competency-based medical education. Competencies, including professionalism, are learned and developed over time. Longitudinal learning requires longitudinal guidance and longitudinal assessment for learning. Said differently, the understanding in the growth mindset is that a learner's ability, skill set, competencies are not fixed and they're not predetermined. With sufficient guidance as well as effort on the part of the learner, including the experiential cycle that requires reflection on action and reflection in action, the learner can develop competencies in all of the different spheres. In order to help them on this journey, they need coaching or mentoring, or both. They need individualized feedback, and they need a longitudinal framework so that individual challenges don't become overwhelming and create forward progress. This requires thinking about assessment to be not only of learning, but for learning. This fits very nicely with the notion of programmatic assessment, where multiple low-stakes assessment moments are ultimately combined to form composite decisions that relate to promotion and progress through a curriculum. This removes in some way the high-stakes nature of every assessment moment and allows a mentor to help with a trajectory even when they're providing feedback in a particular assessment moment. They're not, in essence, on their own, making a pass-fail decision about the learner's progress. To look at this more clearly and distinguish traditional assessment from programmatic assessment, although I'm certain that many of you are quite familiar with these concepts. In a traditional assessment model, all of the competencies, and I've used here the competencies from the CANMEDS framework that I mentioned earlier, are tested in multiple assessment modalities. Imagine here that all 7 competencies are tested through various items on the multiple choice exam. This then leads to an MCQ exam grade. The same 7 competencies are then tested in an objective structured clinical examination, which results in an OSCE grade. Again, these same 7 competencies are assessed in a work-based assessment and then form a work-based assessment grade. The challenge is that passing each of these assessments individually does not necessarily mean that you've passed or achieved sufficiently in each of the individual competencies. It is theoretically possible depending on how the assessment is structured and depending on the specific assessment items, to pass a multiple choice exam that addresses all 7 competencies while actually not succeeding on any of the items related to collaboration. Similarly, one could have difficulty with the same competency of collaboration in the OSCE and struggle with the same aspects of collaboration in work-based assessment. Yet, depending on the structure, pass each of those individual assessments and be allowed to progress through the curriculum. If we instead function in a programmatic assessment model, we are now looking at competencies and we're trying to add things or look at things in composite that are related to the same competency and not to an individual type of assessment tool. In this case, items related to medical expert competency from multiple choice exams, OSCEs, and work-based assessments are combined to form an understanding of the learner's trajectory on the medical expert competency. The same is then done for professionalism, where items from an MCQ, OSCE, and work-based assessment are all considered together as they relate to professionalism. The same is then true for health advocate, as MCQ, OSCE, and work-based assessment items that relate to health advocacy are considered an aggregate, and so on for each of the 7 competencies. Looking at it in this way, you can see that by combining different assessment modalities and thinking of them in terms of competencies, it's easier to be certain that learners are achieving the competencies that we want, even though we're looking at them through multiple different assessment modalities. Programmatic assessment is often referred to as one way to ensure that there's assessment for learning. Passing course-specific evaluations is necessary, but it's insufficient to tell us if a student has met the objectives of a program overall or is attaining the competencies. Frequent low-stakes assessments are used in programmatic assessment, which can include entrustable professional activities, often referred to as EPAs, in-training examinations, logbooks, portfolios, and various other types of assessment. The composite of all of these low-stake assessments then allows one to form an overall impression about the learner's attainment of objectives, milestones, and competencies. In order to do this, specific feedback is required to the learner as well as to the program. The teacher may provide detailed and structured narrative feedback that has to be related to the learning objectives and growth-oriented in order for it to be of help to the learner. One way to do this would be with a form similar to the one shown here. In this case, a learner is provided information on what they should keep doing, what they should do more of, what they should do less of, and what they should stop doing in order to continue along their trajectory. This helps the learner focus both on their successes as well as their areas for growth, keeping in mind that with a growth mindset, there's always room for improvement, even when you're achieving well. And there's especially room for guidance when things are going a little bit off track. By keeping the feedback related to the learning objectives, it helps the learner know where they are compared to what the program expects. Such narrative feedback is often accompanied by checklists. In the case of entrustable professional activities and work-based assessment in a competency-based medical education model, these checklists are generally framed in competency-based terms. Specific elements related to the EPA or work-based assessment are either not observed, in progress, or achieved. When a competency is achieved, this allows the learner to know that they've met the expectations of the program and are, in essence, considered competent for that piece of the overall puzzle. When something's in progress, that helps the learner know that there's still ongoing work that's needed. The narrative feedback then helps them understand how to shift the needle from in progress towards achievement. This checklist and narrative feedback often feeds into a judgment about entrustability. It's important to note that even though this is a judgment, it's still not a pass-fail decision for an overall competency or affects directly the learner's standing in the program. This is instead a judgment about entrustability for a very specific observed encounter and a very specific set of objectives related to that encounter. Entrustability is about the degree to which the supervisor had to intercede in the interaction. If the supervisor had to take over, had to talk the learner through it, or had to prompt, then the learner is considered not to be entrustable yet. If instead they only needed to be there just in case, or didn't need to be there at all, the learner is considered entrustable, and in many systems is considered to have successfully completed an individual EPA or work-based assessment form. This rating and overall judgment about entrustability should always be accompanied by narrative feedback. This is, of course, important when a learner is not yet entrustable in order to help them get to the level that they would like to achieve and that the program would like for them to achieve. However, if you have already had to take over, the learner has seen you in action and has hopefully learned something from your role modeling and from observing you in action. If you had to talk them through it or prompt, you've already provided some feedback through that teaching and learning process. Therefore, the comments help to be explicit about the feedback already provided. If you only needed to be there just in case or didn't need to be there at all for the interaction, the learner has probably received very little feedback during the interaction, and these comments will help them by reinforcing what they're already doing well and providing suggestions for ongoing growth. In some cases, something the resident needs to improve may actually not be something that's a lacune or something that's weak, but may actually just be an area for future growth. Now that we've spoken quite a bit about all of the roles of learners and teachers in a CBME program, we need to talk a little bit about the structures that can support this. Sticking with our bridge building analogy, the learner is building the bridge. The teacher is scaffolding this process and providing a safety cord. And the role of the competence committee, or committee by a similar name, sometimes referred to as a promotions committee, is to inspect the bridge and make recommendations to the learner and mentor. Let's discuss this in a little bit more detail. We already talked about programmatic assessment. If we layer on what programmatic assessment looks like in a competency-based medical education model, the competence committee is reviewing, interpreting, synthesizing data that's provided through programmatic assessment, and then determining what actions are required. In other words, they're making judgments about how a learner is doing overall with respect to each of the required competencies in the educational program and providing a plan for future direction. If we go back to Kolb's cycle of experiential learning that we already looked at for learner activities and teacher activities, we now have the opportunity to layer on the activities of the competence committee on top of this cycle. In this case, the learner activities remain on the slide in black, the teacher activities remain on the slide in blue, and the activities of the competence committee are being superimposed in red. So as the learner is doing things and is observed by the teacher for individual activities, the role of the competency committee is to first review the data that's being provided. And this is not related to a single activity, but rather to the learning activities in aggregate and the assessment activities in aggregate. While the learner has the responsibility to think and the teacher to provide feedback on a specific learning activity, the role of the competency committee is to interpret what's happening with the aggregate of activities. Similarly, while learners conclude and teachers guide, the competence committee is in the business of synthesizing the data. And the role of the competency committee differs the most in the phase where a learner in active experimentation has the role of adapting and the teacher supports that process, the competency committee actually has to act, make a final decision about the learner's progress, and also make recommendations to move forward. The competence committee is usually composed of faculty members with a good understanding of the educational program. This requires the committee, to be chaired by someone with educational experience. It often also includes the program director or the educational leadership of the educational program, and individual faculty members who act as primary reviewers of all of the data about an individual learner. These may be the same people who act as coaches or mentors in the program, but may be different people in order to allow summative decisions to happen at competence committee, while individual coaching, mentoring, and guidance decisions along the learning growth trajectory are left in the hands of coaches and mentors to help the learner in action. The competence committee receives data from multiple assessment moments, which includes exams, assignments, work-based assessments, and APAs, as we've already discussed. And of course, mentors, coaches, and individual teachers may act as raters for any of those moments and be contributing data to this process. The competence committee, after their data synthesis, makes decisions about the learner progress in various competencies, as well as overall through the stages of the program, and eventually decisions about the transition to independent practice, depending on your educational model. The competence committee also has an important role to inform the future actions of the learner and the mentor. This can include providing the learner with some suggestions for areas for ongoing growth when everything is on track, to explicitly requiring remediation and a deeper focus on specific competencies through structured learning activities, a change in the rotation structure, and even sometimes remediation time with a prolongation of training in order to allow the learner to meet the necessary competencies and become ready for transition to independent practice with sufficient expertise. This also informs the mentor, who may be called upon to assist the learner with very specific remediation activities, or simply to continue to act as a guide, coach, supporter, and scaffolder as the learner continues to successfully build their bridge between novice to expert. In conclusion, using the model of building a bridge, the learner is primarily responsible for building his or her own bridge as they transition from novice towards expertise, recognizing where they are in their building path, what tools they need, what experience they need, what support they have to seek, what deliberate practice they require, and that the pathway in medical education, and indeed in a career in medicine, is one of always trying to reach for expertise that is continuously just slightly out of grasp, given the rapid evolution in biomedical science, clinical medicine, and medical education. The teachers are responsible for scaffolding the learner's bridge building through participating in assessment moments. If they're fortunate enough, they may also engage in longitudinal mentorship, sometimes involving coaching, and will always apply a growth mindset to their interactions with learners when providing feedback and providing input into what the learner can continue to do to either remain on a successful trajectory or transition towards a more successful trajectory if they've veered off course while building their bridge. The competence committee functions as the bridge inspectors. They determine the learner's progress and make recommendations to the learner and mentor to ensure that ongoing learning is successful and aligned with program goals and the expectations we all have for our medical professionals. Thank you so much for engaging with me in this session, and I look forward to hearing any questions and comments that you might have.
Professor Ben for your presentation, and the message is that there's a significant role of faculty in hand-holding the student learners at the beginning of the process, and to start with the coach and then help in building for career and giving support for lifelong learning. If there are any questions, they can be posted on the WhatsApp chat, and the answers could be forwarded and shared with them in the WhatsApp group. So with this, we conclude this session. We move to sessions.
Good morning, everyone. So let's hear from our next eminent speaker about training students to deal with complexities under CBME. So the purpose of competency-based curricula is not to prepare students to provide structured answers to patients' problems, rather it is to prepare them to solve their problems. In the process, the physicians often have to work hard with complexity. So let's prepare students to deal with the complexities under CBME. The chairpersons for the session are Dr. Anil Kapoor and Dr. Chetna Desai. May I request our chairpersons to kindly introduce our speaker.
Thank you. So we are happy to invite Professor Stewart Menon and Stalwart Medical Education. He's Professor Emeritus Cell Biology and Physiology from University of New Mexico School of Medicine, New Mexico. He is Adjunct Professor, Department of Medicine, University of Health Sciences, Bethesda, Maryland. He is Consulting Associate, Human Systems Dynamics Institute, Sao Paulo, Brazil. So this presentation, training students to deal with competencies under CBME. Can we have the presentation?
Greetings and hello. I'm Stuart Menon, speaking to you from Sao Paulo, Brazil, and I want to share with you some ideas about preparing students to learn, manage, and work with complexity and uncertainty that comes with it. Let me share my screen with you and begin with this presentation. Just one moment, please. I want to begin by talking about how to prepare you for uncertainty and complexity, because it is the world that we're living in today. And what we will do in this presentation is, recognize the difference between order and disorder, complexity, chaos, and uncertainty, and order and certainty. because dealing with complexity means that you recognize when situations are complex and when they're not, and you act accordingly and appropriately. And I want to share with you 3 ways to manage in uncertainty that will work for you all the time. And then at the end, I'll ask you what you will do next to deal better with complexity and uncertainty. So to begin with, I want to make a central point in this presentation, and that is all learning is experiential. All learning involves complexity and uncertainty, because before you know, before you understand, you are in uncertainty. You are in a complex state. So all learning involves experience, complexity, and uncertainty. And there are 2 kinds of learning that you experience in medical school and before and after medical school. One is the traditional approach to learning in school, which is repetition and replication of finite, predictable things. So there are theories, concepts, ideas, and experiences from the past that we want to continue, we want to share. And so we replicate them, we repeat them, and we bring them forward for students to learn. And then this is the traditional Flexnerian education, where particularly schools tend to have an emphasis on basic sciences before the clinical sciences. And so this replication is very big, important in the sciences basic to medicine, and experience is much more emphasized in the clinical education as it comes later. And then there's the approach for early and sustained sources of uncertainty. How to train students to deal with uncertainty and complexity is to introduce uncertainty and complexity from the beginning of medical school. It's not that we need to solve complex problems, because complex problems don't have solutions. Complex cases, complex issues in problem-based learning, in team-based learning, in simulation, in case presentations and clinical skills, we need to encounter both known and unknown issues, both simple and complex issues, so that by the time students reach their final years of medical school, they've had years of comfort and familiarity with complex issues and complex problems. It's not just things that happen at the end of medical school. Examples include community and family health and the social determinants of health, and where there is care, where there is no cure. So let me make clearer for us the difference between finite or orderly issues and infinite or disorderly complex issues. In finite known issues, there is a problem and it's to be solved. There's a single root cause, and the objective is to find the root cause and deal with its cause and effect. There's a clear beginning and a clear end. There's a story to be told that starts and stops. And under these conditions, what's known as best practices. Best practices are what the literature says works best. Best practices work very well in finite, clearly defined situations. And in these situations, expertise is really important. When you don't know something as a student or as a practitioner, you go to others who you feel can help you. You go to experts. And so expertise in orderly, finite situations works really well. And we know that these situations repeat over and over again over time. And so we gain experience with these situations, and it takes years to gain experience with multiple situations and gain comfort. And when we evaluate and we deal with replicable and repeatable situations, numbers are important. The numbers in laboratory reports are useful. The numbers in clinical trials are useful. The numbers are useful in finite problems. And finite problems have rules that we follow. The rules and expectations. First you do this, then you do this, then you do that. And so there's a procedure and there are rules to follow and what to do. And when you are engaged in finite problems and problems that have solutions, the objective is to find the solution. The objective is to win, to get diagnosis correct, to treat correctly, to get the most points, to get the highest score, to publish the most papers, to gain the most something or other. So the objective in finite is to get the solution, get the right answer. And examples could be to set a simple fracture. There's a beginning and end. Expertise matters. You've seen many of these before, and they look familiar. There's rules to follow, there's best practices, and there's a single root cause that you can deal with. Same with interpreting laboratory results. You learn how to interpret a blood smear or a blood count or a gastrointestinal panel of laboratory issues. You know what the normal range is, and you can interpret highs and lows and no differences. What about problems that don't have answers? What about problems not only where you don't know the answer, but there is no answer? What about problems where the objective is not to get the answer, but to deal with the problem in some way? Because where finite problems have a single root cause, complex problems have many causes, and it's not possible to identify the root cause. And the problem doesn't start and stop, doesn't have a clear beginning and end, it's continuous. An example would be chronic disease. An example would be aging. The problems keep going, and sometimes best practices don't work. There are many issues in medicine and in medical education where there isn't an established best way to do things. You have to work at them and discover what works and do that. And in these conditions, inquiry matters, whereas expertise matters in orderly, defined situations where there's a solution. Where there's no answer and no known solution, inquiry is much more important than expertise. And we see these patterns re-emerge over time. We see patterns in poverty. We see patterns in chronic disease amongst patients. We see patterns in community health. And whereas numbers are useful in finite specific issues, in complex issues, what you see is that stories are useful. Stories are like someone's history, someone's story is absolutely the most useful. When you really don't know what's going on, when you're calling someone for help, you need to be able to tell the stories. And the rules don't always work. Being innovative and creative sometimes requires you to break rules because the rules don't apply, and change expectations. And the whole point of dealing with complex issues is not to win, not to get a solution. There is no solution. The whole point is to keep playing and keep going, keep learning, keep moving. And examples would include geriatric patients or social determinants of health. So these are the differences between orderly, finite issues in medical education and in medicine. And these are the characteristics and differences in complex issues. And so the approach for orderly and finite issues where problems have solutions does not work in infinite, complex, chaotic issues where patterns shift all the time. You need two different approaches, and you need to be able to recognize when to use which approach. And that's the take-home message of this presentation. So I want to characterize. So what do finite orderly issues look like in medicine and in medical education? Well, an example would be a prescription. When you open a bottle of medicines, you expect each pill to be the same quantity and same quality. You don't want variation. You want replication and you want specificity. The same when you take your COVID vaccine, you want to know that that vaccine is from the manufacturer and has the specified amount of material in it. You want replication, you want certainty, you want a beginning and end to that injection. Same thing when you're looking at material under the microscope. The slide doesn't change. The sample may change, but the slide is fixed and finite. There's a certainty in the description from a pathologist. When you're doing your budget, the numbers are fixed and you work within that budget. So budgets and numbers are important and they're fixed. The same thing with checklists. We use a lot of checklists in OSCEs and different simulations and clinical situations. Checklists are either it's there or it's not. You either did it or it's not. You have a contract, you have an agreement. Either you do the things in the contract or you don't. There's no in between. When you're a medical student learning basic sciences, you learn about the relationships and you expect to see aortic pressure and pulmonary pressure. You expect to see heart sounds. You expect to see valve pressures and chamber pressures. You know that there's a fixed relationship between them, even though the data may vary. When you design a curriculum, you have modules, the first module, second module, third module. It may change every year, but the sequence and the structure of the curriculum is fixed. It's exactly, and every year you know it's going to be the same. So these are finite and certain kinds of problems in which orderly expectations proceed, where you play to succeed and you expect to win. What might infinite, uncertain complexity look like? What are the kinds of problems and issues that you're going to deal with for which you need experienced working with complexity and uncertainty? Well, first and foremost is what we're living through right now, which is the pandemic. So even though we have vaccines, not everybody has access to vaccines. Even though we have vaccines, people have breakthrough infections. Even though some people are vaccinated, some people are not, there are variants, and the transmission and the spread of disease is something that we can observe, but not something we can necessarily control, even though we wear masks and take precautions. Working in a healthcare team is uncertain. It's complex. You cannot predict exactly what's going to happen. You don't know what people are going to say and do, and the same team doesn't work the same way every time. Each time you interact, it's different. Public health, population health, it's only predictable in a large epidemiological sample. It's known, but you can't always predict what's going to happen. We didn't know what was going to happen with COVID. We couldn't predict that there would be an outbreak of this virus. Working in highly infectious conditions, you need teamwork. You need to be able to work and collaborate even when you can't communicate so effectively. What about diseases like cancer? Completely complex, unpredictable, and you need different strategies to work with this. How about your personal relationships, your family life? You cannot predict what's going to happen in your personal relationships. You have to live them. You have to stay constantly engaged to understand and develop personal relationships. These are complex events. This is an example of complexity. What about bedside discussions with patients? What about giving news to patients? What about explaining things to patients? What about their understanding? What about their compliance? These are things that are not fixed, that are not guaranteed, and you need to be able to work with them on an ongoing basis. And almost finally, what about culture? Different approaches. This is a Navajo lady from Southwestern United States with her baby. This is how babies are kept in that culture. And this is a Native American healer, a curandera, or a medicine woman working with a mother and her child. So there are complex issues in natural healing and native approaches. And finally, there's mental health, completely unpredictable and something you cannot deal with with a formula. You need to be able to work continuously. So all of these uncertain events require continuous work. You cannot start and finish. You need to be able to work with them and learn and engage in a continuous way. And that's very different than finite and certain problems, which have a beginning and an end. So the first thing you have to do as a student learning to deal with complexity, and as a teacher helping students to learn to deal with complexity and uncertainty, is to know the difference between the situations that are certain and uncertain, and to be able to use the approach that works best. So to go a little bit further, before we go into the approaches that bring order out of chaos, let's take a little closer look at what the difference is between order and chaos in order to learn better what kind of situation we're dealing with. Certainty, certain situations A good example of certainty is a procedure. Cooking, following a recipe is a procedure. Working in a gross anatomy laboratory following a dissection is a procedure. Doing a spinal tap is a procedure. Taking blood pressure is a procedure. You have steps 1, 2, 3, 4, and you follow the steps as you go. And so following the steps, you can predict what's going to happen. You can achieve a standardized product. You can achieve you can have an optimistic approach to the problem solution. You know you're going to get the result if you follow the procedure correctly. And the procedure is developed by experts. You don't need to develop the procedure yourself. You just follow it. So in situations where you're following procedures, or you need to learn a procedure as a student, or as a teacher, you need to help students to learn a procedure. These are simple, finite, everyday kinds of events. This is simple. This is not complex. There are situations where the number of moving parts is really big, and the trajectory of the moving parts becomes really important. So putting a rocket on the moon requires thousands of hours of work, thousands of components, and everything must work exactly correctly. And you can predict the trajectory of the rocket. You can predict the landing site. You can predict everything. Where prediction is really important. So in complicated, like simple, prediction is essential in the workings of a very finely tuned watch or clock. There are so many moving parts that sometimes it's hard to establish which ones are most important, but careful examination can lead you to where there's a problem. You can locate the problem and you can fix the problem, and the watch begins to work again. So this is finite known event. So a recipe, a procedure, a series of multiple things that are connected in a cause and effect way. These are simple and complicated events for which there are solutions. And you should know when you're dealing with one of these. A complex situation would be raising a child. It's nothing like a procedure. The procedures don't work. There's no formula for raising a child. Raising one child doesn't predict that the next child will be the same or work easily for you. Expertise is useful, but it's not enough to ensure success as a parent. Every child is unique. The situation is unique. And while you can understand the individual, you can't understand children. Formulae and procedures have limited application. And in this situation, what you do is you live with your child, you live with your family, you live with your significant other, and every encounter is a learning experience. You learn by doing and reflecting and learning. And so examples of complexity in medical education would include trust. There's a lot of literature and a big emphasis on entrustable professional activities. Trust is important, but trust needs to be developed over time, over multiple encounters in a relationship, and it's complex. Developing shared meaning and sustaining shared meaning requires continuous interaction over time. Integration in a curriculum requires many, many moving parts connecting and understanding emerging from integration. Early and sustained contact with patients and communities as part of medical education is a way to introduce complexity into early medical education. There's a lot of emphasis on authentic context, learning with real patients, learning in real situations, learning with the most authentic experience possible, assessment being authentic and reflection being involved. Cooperative learning, teamwork, team learning, small group work, very complex, not something that you can predict and control. And then there's what we call permanent education, that is staying curious your whole life. Permanent education means asking questions, doing actions, reflecting, seeing what's new, asking questions, taking actions, reflecting, and so on. And finally, what does it mean to be a human being and be a medical student? What does it mean to be a human being and be a teacher, to be a clinician? What does it mean to be a human being and be a patient or a student? So paying attention to the humanity of things is really important all the way through. It's not some separate course that you take as part of medical education in ethics and professionalism. It's embedded in all of these activities. It's something that we do all the time. So just a quick departure very quickly into the structure of complex situations, just to illustrate why it's important to look at the outcomes rather than to look for the solutions to outcomes. When you have complex systems, you have multiple interacting parts. Each of these colored geometric figures represents maybe a faculty member, and all of this being a department. Maybe it's the students in the class. Maybe it's a patient, a nurse, someone who works in the hospital, the admissions person. Maybe it's a physician. Maybe it's your small group that you work with as a student, the different people in your clinical team. Maybe it's a small group problem-based group of students with a facilitator. It doesn't matter what it is. What you see that's common and constant is you have multiple individuals that are in themselves complex, interacting in multiple ways, not interacting in cause and effect, not interacting as linear events. So in simple situations, you have external causality. That is, you have an effect where one thing causes another thing, which causes another thing, which causes another thing, and it's external to what you observe. So in simple expertise-driven ways of looking at things, what you see is that there's external causality, whereas in complex human relationships, in complex situations, the interactions inside amongst individuals, the internal interactions are very important. I'll give you an example of internal interactions that are important. If you are a teacher of medical students, you can be the best teacher in the world, but students may not learn. You cannot, as an external force, guarantee that students learn. You can present the material really well, you can be a terrific teacher, but it doesn't mean people learn. The students have to be ready to learn. They have to decide. They have to internally be ready to learn. They have to be open and prepared to learn. Unless that's happening internally, the external force doesn't make any sense. So in complex situations, it's the internal dynamics that prepare the system to be responsive to conditions. And then it's the conditions amongst individuals that help prepare that preparation. So what happens is you have multiple interactions and you cannot decide where the root cause is. And as a result of multiple interactions, what happens is that there is just a second. As a result of complex interactions, there's a complex, this is having a technical problem here. Let me just solve, this is a solvable finite technical problem. Now I've just found the solution. So this is a problem that has an answer that I just found. And so the next slide shows that when there's multiple interactions, a pattern emerges, not a single event emerges, but a pattern emerges. So for example, when you go to hear music, when you hear a band play or you hear a symphony play, you see multiple musicians, like these figures down here, that interact together. And what emerges is the totality of the pattern of the song, of the music. You hear the totality. You don't hear each individual musician playing alone. You hear the whole thing. So patterns emerge in complex systems. In a medical clinic, when you walk into a medical clinic, you see the receptionist, you see the reception area, you see the patients, you see the doctors, you see the nurses, you see technicians, you see the whole clinic. You have a sense of the clinic. If you went to a different clinic, you would have a sense of a different clinic. There's a pattern that exists in complex situations. So recognizing the pattern rather than looking at individual parts is very important, and helping students to recognize patterns in clinical situations, patterns of illnesses, patterns of communities, patterns of family health are important, because those patterns influence the actions of the students or of the clinic in future interactions. So the music that the musicians hear influences them while they're playing to play the next part. The way that clinic operates on any particular day influences the people that work there to interact. So that there is a dynamic of an emergent pattern which then influences future actions of the parts. So these are simple, complicated, and complex situations. This is the difference between knowing the answer to a problem and seeing a pattern emerge in a complex situation. So you must be able to tell the difference between the two. First question you should be asking yourself is this simple, complicated, or is it complex? Is this like many moving parts that are causally related in a way that I can take them apart and put them back together again? Is this a procedure? Is there a known answer? Is there someone who can help me answer a question here? Can I look it up? These are known finite issues. Is this one of those? And do I need to find the answer and get help? Or is this like culture? Is this like family? Is this like a group teamwork where I cannot find a precise, predictable answer? I need to work in the group and work continuously to have the best approach to a complex situation. So what are ways to manage in uncertainty and complexity? I'm going to show you 3 approaches you can use to deal with complexity and uncertainty. And the first thing to know is that all change begins with conversation. So unless you're ready to interact with other people, you're going to have a very difficult time solving complex problems. So learning to manage an uncertainty, the first approach is to ask a lot of questions. So you can manage an uncertainty because there is no correct answer. The best tool you have is questions. Now you need to ask questions and stand in inquiry, and you need to turn judgment into curiosity. You can't decide that this is the way it's going to be. You can't make a decision right away because you can't predict what's going to happen. You have to stay in a state of curiosity. You have to be open and curious all the time. You have to, when you are engaged in conflict, you have to have shared exploration. You know this from your group work. But conflict doesn't mean necessarily personal difficulties. It can mean that, but conflict also means data that doesn't agree, data that conflicts one piece with another. You have certain data from this lab result, you have this data from physical exam, you have this data from the history, and it doesn't all agree. Under those conditions, you need to go into shared exploration. You need to explore further. You need to ask more questions. So is this a situation where the data is known? Or is this a situation in which the data is incomplete and I still have to make a decision with incomplete data? Am I being defensive in my teamwork, in my group work? We all have experiences where we feel defensive, where we feel insecure, we're uncertain. Under these conditions, not shared exploration, but self-reflection. This is a mistake. Excuse me. I can't fix it right now, but this should say self-reflection, not shared exploration. So self-reflection is the way to deal with defensiveness. And finally, we all make assumptions about what we're observing. The assumptions are that there's going to be another slide. The assumptions are that I'm going to be talking. The assumptions are that I'm going to explain everything to you and you're going to learn everything all in 1 hour. And my understanding is that I'm going to question whether that's true or not. I don't think you're going to learn everything in this hour. I don't think you're going to get everything. I don't think I'm going to give everything. I'm going to share what I have to share, and you're going to learn what you're ready to receive and understand. And maybe you'll need to see this more than one time. So the assumptions I have are that you're not going to get everything from this presentation. You're going to get something, and I don't know what that's going to be. And so there are different ways to deal with questions and inquiry. There's a technique which I'm calling question storming. You have brainstorming, but this is question storming. When you have an unknown situation that's complex and you can't find the answer, you ask questions without answers. So what if you asked questions but didn't try to answer them? What if you had a complex problem that you could explain in 3 to 5 sentences? So for example, my complex problem is I'm speaking to a screen. I don't see anybody that I'm talking to. I don't even know who's on the other side. And my issue is, how do I know that anybody is learning anything or getting anything from what I'm saying? So my sticky issue, my complex issue is that I have great uncertainty about the effectiveness of what I'm speaking about and what's going on. And the only thing I can do is to ask questions. And the questions I ask have to be open-ended. I can't ask a question and expect an answer. How do I know that people are learning is an open-ended question. What does learning actually look like for you? What does learning look like for me? What does learning look like for other people, your teachers, your administrators at your school, your government people? It looks different for everybody. And so that's not a closed-ended question. I'm not going to ask a question that requires giving advice. For example, here's a question that gives advice. Don't you think you should write everything down? That's a question, but it's giving you advice. Why aren't you writing everything down? So you don't want to ask questions that give advice, that are disguised as advice. And especially when you're taking history from patients, you need to be very careful about not leading the patient, but having open questions where appropriate and closed-ended questions where appropriate. And finally, you want to ask questions where I don't have the answer. If I say, I wonder how people are learning in this talk, it's beyond my knowledge. I don't know. I'm not giving advice, and the question is open-ended. This is the quality of the questions you need to ask in a complex situation. And so when you've done that, at the end of so what you do is for 10 minutes, and it's best to do this with someone else, for 10 minutes, you just ask questions, but you don't think of the answer. You don't answer the questions. You're not expected to answer the questions. You don't try to answer the questions. You just ask questions. And maybe there'll be 30 or 40 questions asked in 10 minutes. What happens is when you hear all those questions, something triggers with you, there's question storming going on. Some questions stand out. Something is a question that you think about, I could do that. That's reasonable. That's promising. I can get a short-term response. Within all those questions, something stands out and connects with you. So instead of looking to the answer to each question, you listen to all the questions and choose the questions that seem most reasonable and promising for you. It's called question storming, and it works great in groups. And if I had more time, I would love to do it with you. So the first approach is to ask questions, lots of them, and to question storm, and to stay in inquiry. The second approach is to focus on problems, not solutions. To focus on patterns, not problems. I'm sorry, to focus on patterns, not problem. What's a pattern? A zebra stripes are a pattern. You can't really know a zebra by looking at one stripe, or even 2 stripes, or even 5 stripes. You have to see the whole zebra. If we just saw the stripes, we wouldn't really know much about this animal. We wouldn't really know much about this knot unless we could see and play with it and explore it. So what we know is that simple solutions don't work with complex problems. You have to understand that you're looking at a complex organism in order to be able to go forward. And so you look for a pattern. So how do you look for a pattern? You ask questions and see what emerges. You zoom in and zoom out. You could zoom in on these knots and zoom out, and you get a different perspective on the pattern. you find a pattern that's not only true, but it's useful. Usefulness in medicine is really fundamental. So something may be true, but it may not be useful to you. So, for example, you may have lab data that's correct, but it's not useful. You may have a suggestion from someone that's true, but you don't find it useful. And finally, you need to take action that's adaptive. You need to be able to act, reflect, and re-examine the situation. I'm going to talk in just a minute about adaptive action more specifically. So how do you focus on patterns, not problems? You ask some simple questions. Again, we're at inquiry, questioning in complexity. What do you see in general? Well, in general, I see an animal with 4 legs, a head, a tail, and stripes. In general, I see this. On one hand, I see black stripes that are thin. On the other hand, I see white stripes in between black stripes. I see 2 ears and a tail. And I'm wondering what kind of animal this is. Doesn't look like a horse. I'm surprised that every zebra looks different. I would expect the stripes pattern on each zebra to be the same. But I'm surprised by the pattern of zebras. And I'm also surprised about how the shapes change when a zebra moves. And what I'm wondering is why zebras have stripes? Why don't other animals have stripes? What is the advantage for zebras having stripes? And what do patterns on animals, what advantages do patterns of coloring, of camouflage, of feather shapes, how does that work in the animal's existence? So what you can do with a complex medical problem or medical education problem is make a little worksheet, just write down in general, on one hand, on the other hand, I was surprised by and I wonder. And do that in a complex problem. Don't look for answers, just do this. And you will see a pattern that emerges. And once you see a pattern, you can ask, what's going on? What does it mean? And what will I do now? So what generalities, contradictions, and surprises and puzzles, and what do you wonder? So now with all of that, what emerges as possible? Very much like question storming, asking what's going on, seeing what does it mean for you? Making meaning is the most important part of complex problems. Because there's no answer, you have to make meaning with incomplete information and in the face of big uncertainty. And the more you practice that, the more you realize that what it means to you is important. It doesn't necessarily mean it's correct, because there is no correct answer. There's only an answer that you can try. So what you do is you take action that's informed by meaning that you make by what you observe in the pattern. You observe a pattern, you make meaning, and you see what happens next. And then based on that, you go forward. And that is the third approach. So the first approach is to ask a lot of questions. The second approach is to focus on patterns, not problems. And the final approach is to keep moving, keep learning. Adaptive learning, adaptive work is important. Look at this graph. This is a graph that I call permanent education. It comes from the work of Anders Ericsson, who looked at performance on the y-axis. This is a conceptual graph based on data. Performance on the y-axis, experience on the x-axis. Here, this first curve is what happens when you do, this would be an example of learning a new software. You get a new app on your phone, you get a new software for your computer, and it takes you about 10, 15, 20 hours to learn the app or the software so that you can flow with it, you can use it. And then you don't have to think about learning it, you can just use it. So there's a learning curve and then it goes flat very quickly. So the performance is at a low level and the experience required is very low. What about going to medical school and graduating and going into practice? What about doctors, professionals, you know, that have been in practice for 10, 15, 20, 30 years? Are they still learning, or are they stuck with all the things they learned in medical school and they have not developed further? There's an arrested development. They have not kept learning. What about experts? Experts, one of the things that makes experts expert is not that they know more, it's that they keep learning more. They keep learning, that they stay in performance-based learning much longer than non-experts. And then finally, what I call permanent education. I've added this curve, that if you are a student and you stay curious and you do shared exploration and you stay reflective and you challenge your assumptions with questions, you'll always be on an upward moving curve. Whether you're a student, whether you're a postgraduate, whether you're a teacher, whether you're a practitioner, whether you're retired, you will continue to be engaged, continue to be alive and vital. It's what keeps people vital in life. So the final strategy that I want to talk about before I finish is called adaptive action. And it works for, this is called wicked issue. It works for complex issues. Wicked in the sense that it has no answer, difficult to solve, not evil. It means difficult, no answer, no solution that's fixed. You need to ask yourself, what is the current pattern that I'm observing? So you know the difference between a pattern and the individual stripe on a zebra and the pattern of stripes. So what do you know for sure? And what do you wonder about? And so what does it mean for you? What's the next wise action? So ways of asking, what is happening right now? What do we know for sure? What's the literature say? What are people saying? What am I observing? So this is what. And after you do all of this, you start to make meaning. So what patterns do we see? So what resources are available? So what stories have we heard about what works? So what do we wonder? So what options do we have? What does success look like? What is possible? What is within my reach? And then you take an action based, not on a right answer, an action based on the meaning you make. You make meaning. You're a student, you make meaning. You're a postgraduate, you make meaning. If you don't have to have the right answer, there may not be a right answer. So what we'll do now, what will you measure now? What will you communicate? You do something, and then after you take an action, you look again and see what's happening now. What do we know now? How does this fit with what I know from the literature? And now what does it mean for me? And now what am I going to do next? And then what does that look like? And then what does that mean? So there's an iterative cycle of adaptive action where you ask 3 simple questions. What do I observe? What's going on? So what does it mean for me? So what is accessible? And now what am I going to choose to do? And these 3 actions, asking lots of questions, focusing on patterns, not problems, keeping moving through adaptive actions, what, so what, and now what. This is how you learn to deal with complexity in medical education, in medical practice, and in life. So my question for you is, now that you've seen what, and we've reflected on what it means, now what's one thing that you're going to do as a result of this talk? What action are you going to take? What meaning are you going to make from this presentation? And what's the one thing that you'll do next, today or tomorrow, that's different? Will you ask, is this simple or is this complex? Does this have a right answer, or does this have no real right answer, and I have to work with it by asking questions, looking for patterns, and keep moving and keep learning? So that's what I think it takes, and that's what I think you need to learn to deal with complexity in medical education and in practice. And I really appreciate your time and your attention with me, and I want to say thank you very much. And if you have questions for me, here's my email, and I'd be happy to interact with you, because the interaction and questions are the most important thing for me. And in my learning, questions help me to learn. So I want to thank you for your time and attention, and thank Professor Singh. And I look forward to speaking with you and your questions and comments if we have time. Hopefully that we do. Thank you very much.
Under CPA. Okay, so we had a quick overview about the differences between the finite and infinite issues, and particularly about the infinite issues which don't really have a definitive answers and which are marked by a lot of complexities. But at the same time, we also saw some examples of these infinite issues, and of course, how to manage the uncertainty. A very lucid talk, sir. And if there are any queries, please put them in your chat box. And the email has been given. So Professor Menon would definitely be eager to answer these questions. Thank you all for your kind attention. And here we take a brief break of about 10 minutes and return at 11:15. Thank you.
May I request Dr. Anshu to please felicitate our chairpersons. Dr. Anil Kapoor and Dr. Chetna.
Nice camera.
Thank you, ma'am. Thank you, sir.
Can we have a quick tea break?
Camera on.
So we start the next session after the tea, and the next topic is workplace-based assessment for competencies. Now, it stands to reason that the basic purpose of CBME is to ensure that the graduates are fit for purpose before they enter practice. And this may not be possible with the conventional assessment model. Let's listen to the concept of workplace-based assessment with particular reference to competency-based curriculum. Our chairpersons for the session are Dr. Ruchi Gupta and Dr. Anshu. May I request them to please come forward and have their seats. And Dr. Tejinder Singh. And Dr. Tejinder, please, sir. Dr. Ruchi Gupta is a professor and head, Department of Anesthesia, SGRDUHS Institute of Medical Sciences and Research. Dr. Anshu is a professor, Department of Pathology, Mahatma Gandhi Institute of Medical Sciences, Sevagram, Maharashtra. And Dr. T. Singh is the convener for medical education in SGRDUHS Institute. May I request the chairpersons to kindly introduce the speaker.
Good morning, everybody. Our speaker for this session is Professor Matthias, who's from the University Hospital at the Ludwig Medical University, Munich. He's a senior researcher in the Institute of Medical Education. He's the founder of the Center for International Health at LMU, and he's a consultant in the Department of General Visceral and Transplantation Surgery. He's a medical educator and a member of the Cosima Research Unit on Diagnostic Competencies in Simulation-Based Learning Environments in the university context. He has a number of publications to his credit, and he's also, and as a course director in the undergraduate medical curriculum at LMU, he has implemented several innovations for teaching and learning in medicine. We're all keen to hear what he has to say on workplace-based assessment for competencies, as this is one of the important areas where our faculty need more guidance.
Good morning, ladies and gentlemen. Good afternoon and good evening. Thank you, Professor Tejinder, for inviting us to this prestigious conference on medical education in Amritsar. Please allow me to introduce myself briefly. My name is Matthias Siebeck. I am from Ludwig Maximilians University, LMU, in Munich, Germany. I'm a medical educator and I have been a surgeon for many years. The title of my talk is Making Workplace-Based Assessment Work. It seems redundant to me to discuss workplace-based assessment as it is practiced in industrialized countries who have begun to explore it. I think it's more exciting to see how it can be done in resource-constrained settings. I will therefore concentrate in my talk on two examples, one from a country in Africa and another one from Asia. What is workplace-based assessment? Workplace-based assessment is using the real life for training the learner. This method makes use of the workplace as an environment, not the classroom, not the simulation room. It is testing knowledge, skills, and attitudes at the same time. In my opinion, it is more than an assessment. It is the best and safest method of teaching and learning in the health professions. It just has assessment in its name, and that alone may evoke wrong associations in some people. The concept of workplace-based assessment is embedded in a larger concept, and that is competency-based medical education, CBME. You may think that is something new if you haven't heard it before. Educational scientists have been discussing competency-based higher education a long time ago, in the 1960s and 1970s. It was Dr. William McGahey, a surgeon and medical educator. He published a book with the WHO with the title Competency-Based Curriculum Development in Medical Education. And that was in 1978 Gregorian calendar. It then took a while until appropriate methods for CBME were developed. For example, direct observation of procedural skills, the DOPS, the 360-degree feedback, the mini CEX, the case-based discussion, and so on. Since then, the first newer concept is entrustable professional activities, EPAs, invented by Oleton Kate. His definition: an EPA is a unit of professional practice that can be fully entrusted to a trainee as soon as he or she has demonstrated the necessary competence to execute this activity unsupervised. Now, what is competence? This seems to be a very central concept. Here I am quoting a widely accepted definition of competency in the context of health professions. It is the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. And that was a definition by Epstein and Hundert, published 2002 in the JAMA.
Good morning, Professor Matthias, and it's my pleasure to welcome you to this session of workplace-based assessment during the National Conference on Health Professions Education. So welcome once again.
Thank you, Professor
I would like to know from you as to what is this concept of workplace-based assessment, especially in relation to the conventional examinations and its role in preparing students for future practice.
Okay, thank you, Professor Tejinder, for inviting us to your prestigious conference. The main difference between traditional exams and workplace-based assessment is that workplace-based assessment is a teaching and learning method, and at the same time it is really checking the qualification of the learner for independent practice, whereas traditional assessment does not really place that as a priority.
So if I get you right, what you're saying is that the focus in workplace-based assessment is on the ability of the student to be able to perform patient care independently without any outside supervision. So does it mean that you can use workplace-based assessment for both undergraduate and postgraduate education, or is it only suitable for postgraduates?
Okay. Workplace-based assessment is not giving grades like A, B, C, and D. Workplace-based assessment gives a different form of result. It says this candidate is able to practice independently. This candidate is able to practice with some supervision, and down to the level this candidate is not able to practice alone at all. And for the undergraduates, this clearly means legally they are not able to practice independently. Yeah? So it is, in the true sense of the word, it can be used at the end of the studies when they graduate. But still, for evaluating the main component of workplace-based assessment is also giving feedback on the practice. And that is certainly a true value that is also given in undergraduate studies.
Now, for us, it's a totally, I can't call it new, but what I can say, it's a different concept, because we are used to the traditional university examinations and board examinations and so. So if we were to implement this concept of work-based assessment, do we need to prepare our faculty differently? Do they need a different kind of training?
I think that is a crucial point for the success of it, as with any innovation. Yeah? If you do not invest in training your faculty, probably any innovation is doomed to failure. And those who are doing the workplace-based assessment must first be trained to give constructive feedback. And that is a deficiency in most of the educational cultures on this planet, that there is not enough feedback. So the true value of workplace-based assessment is in the feedback that the learner is getting.
And will it require more time and effort and resources for implementation of workplace-based assessment? Because as I get from what you have said, is that it's a continuous ongoing process rather than being a snapshot observation. So would it mean that teachers would have to invest more time for assessment?
Well, in the past, with the classical assessment system, if you didn't invest into faculty development activities in training those who do the assessments, then the validity and technical quality of the assessments are very low. Yeah? So that's not a different thing with workplace-based assessment. You always get what you have invested. If you invest in faculty development, then you will get solid and valid assessment results. And particularly, the learners will get good feedback.
And lastly, we have introduced a system of competency-based medical education in India for both undergraduate and postgraduate education since 2019. What do you think about the compatibility of workplace-based assessment with competency-based medical education? Do they have a synergistic effect, or do they go in different directions?
From my perspective, workplace-based assessment is one implementation of the idea of competency-based medical education. Nothing else.
So, am I getting you right that for competency-based medical education, workplace-based assessment becomes a kind of necessity rather than being an option?
Yeah. I think the consensus is growing on the whole planet that this is the way to go. Because everybody wants to have safe doctors. Everybody wants to have doctors whom they can trust. I mean, for me as a surgeon, it's vital that I walk out of the hospital and know I can trust the resident who is on call to do the job. Yeah? Otherwise, I can't go home, never.
Okay. So that's another area where I think we should be working on, especially if we have to make the competency-based model a success. So thank you for sharing your thoughts with us. And I hope the participants would get even better ideas when they sit through your session subsequently. Thank you very much.
Thank you, Tejinder. I would like to present to you 2 examples of how workplace-based assessment can work in real life. I will call upon 2 young colleagues to discuss with me about their experience. Okay, ladies and gentlemen, thank you very much. Now I will state the agenda of this keynote lecture. First of all, my colleagues Dr. Karma and Mr. Ikulinet will introduce themselves to the audience. And then in interviews with both Dr. Karma and Mr. Ikulinet, we will discuss the following objectives: why they are doing it, what exactly they are doing, and how they are doing it, the current status of implementation, strengths, roadblocks, and most importantly, faculty development. Also, a sideline on workplace-based assessment in another health profession, anesthesia. And finally, there will be a time for questions and discussing with you, the audience. And now I would like to invite Mr. Ikulinet to introduce himself. Please, Ikulinet.
Okay, thank you very much, Professor. I'm Kulinet Miskanov from Ethiopia. My background is public health and medical educator, and I'm also currently a PhD student in NCHPE Munich. I'm working as education and training advisor in Ethiopia, and especially closely working with surgery residency training programs in competency-based medical education, as well as implementation of work-based assessment. Thank you.
Thank you very much, Ikulinet. Dr. Karma, first of all, would you please identify yourself and introduce yourself to the audience briefly? Thank you.
Okay, thank you, Professor. Thank you so much. So good morning, good afternoon, or good evening to everyone, wherever you are, as per your time zone. And I'm Karma, and I work at the only medical university in Bhutan. It's called Gesagalpa University of Medical Sciences in Bhutan. And at this point, I serve as assistant professor and deputy dean academics. Thank you so much.
Okay, Karma, thank you. Please explain why did your university, the KGU-MSB, want to have workplace-based assessment?
Thank you, sir, for the question. Basically, we are a new university. We started in 2014, and then when we actually reviewed, implemented at various stages of our implementation of our curriculum, we realized 2 or 3 critical points which really made us think that this WPBA is the requirement. One was that the traditional curriculum we had didn't allow much of interaction between the faculty and the learners. And then the second point that we also thought very critical was that somehow the competencies that we are building, we were not sure whether that was the needed competency or targeted competency. And of course, the third one is that we wanted to really explore and go with the trend of 21st century curriculum. So these are the few things I thought it's important to share. Thank you so much, sir.
Okay, thank you, Karma. What is the definition for workplace-based assessment at KGU-MSB?
Thank you so much, sir. I think this I would like to answer in 3 different phases or different areas. One is that for us, when we started WPBA, when we started thinking WPBA in Bhutan, we started by defining what are the competencies that we really want to have in our learners at the end of the program or at the end of the 4 years. And the second thing that we did when we went into WPBA was that what is the level of each of these competencies that we wanted to build in our learners. And the third one is, of course, for us, we wanted to look for appropriate tools. So that's where we actually ended up having a set of tools. And at KGU, we use 4 different sets of tools, which is related to WPBA at this point. Yeah. Thank you, sir. Thank you so much for now.
Okay, thank you, Karma. Now, Mr. Ikulinet, the situation in your country. Why did your Ministry of Education want to have workplace-based assessment, please?
Okay, thank you. The main reason is that the adoption of competency-based medical educations and transitioning from conventional curriculum to competency-based educational framework is one of the main reasons for using this workplace-based assessment. As you know that the traditional content-based medical education has a well-documented weakness, especially in terms of acquisition of the essential knowledge, attitude, especially the skill aspect, so that the ministry adopt the outcome-based competency-based education that will better prepare medical graduates to effectively address the complexity, so that workplace-based assessment is one of the important aspects of competency-based medical education, so that's the main reason for using this workplace-based assessment by Ministry of Higher Education as well as Ministry of Health. Thank you.
Okay, thank you, Equilinit. What is your definition or the definition of your Ministry of Workplace-Based Assessment?
Okay, according to the Ministry of Higher Education as well as the Ministry of Health, they believed that workplace assessment is the main, even I can say that's the most valid means of assessing residents' performance in a real environment. That is the main belief and definition by the ministry. That is the most valid tool and approach to actually assess the actual performance of residents in the actual place. So that is their definition, the working definition of the workplace-based assessment in my country.
Okay, thank you very much, Equilinit. Now, Dr. Karma, could you please tell us when was it introduced?
The new curriculum of CBME curriculum was started in July 2018. It's 3 years ago, sir.
Okay. How was it done?
Sir, what we really did in trying to implement this, firstly develop and implement this curriculum, was that we really had a lot of series of discussion. It was a multi-stakeholder discussion involving the faculties. But when we say faculty, we have faculty also in the teaching hospitals. And then, given that 2 hospitals are far away from Thimphu, so we had one at Gelifu, which is southern Bhutan, and east in Munga. So we have roughly 30 faculties there. So therefore, all the faculties even there, and of course the policymakers at Ministry of Health, including the regulatory bodies such as Medical Council, and not to forget our own students and of course the alumni, because they were the main sort of source for us to really improve on the curriculum and incorporate the right competencies. Yeah, these are the things in brief, sir.
Okay, thank you. What is the current status of the curriculum development cycle of all the different specialty programs in Bhutan?
Thank you, sir. I think it is we have around 11 PG curriculum, and all the PG curriculums, 11 PG courses actually follow the same curriculum. And then at this point, we initiated the review of the curriculum. And then that's where we have been trying to gather information from our own students who have been subjected to this for the last 3 years, and our faculties who have been implementing this for the last 3 years, and of course, the policymakers. So basically, we are towards the end of the cycle where we are collecting feedback to prepare for our next phase and next cycle of reviews. Yeah, thank you.
Okay, thank you, Dr. Karma. Now, the most important question, in my opinion, how did you structure the corresponding faculty development in your setting?
Sir, I think it is like critical to understand. We started our first faculty development program only in 2016. And then after 2 years, we started the CBME curriculum. And in the first 2 editions, we really didn't have anything related to CBME. So therefore, when we conducted our first faculty development program in 2018, after the initiation of CBME, we incorporated sessions on WPBA, sessions on work, sessions on micro teaching, sessions on feedback, because these are critical part of WPBA. And similarly, we also actually developed 2 full-day course of workplace-based assessment workshops for our faculty. And that actually was very critical in the success of implementation of the CBME in NCHPE and in town. Yeah, thank you so much, sir.
Okay, thank you, Dr. Karma. Ecolinette, next question. When was it introduced in your country?
Okay, the workplace-based assessment was introduced in August 2018 according to the Gregorian calendar, along with the adoption of the new curriculum.
Okay, and how was it done?
Yes, of course, it was the introduction was initiated by Minister of Health and the Minister of Science and Higher Education. The initiation was led by those organizations and the national technical working groups, the residency national technical working groups were the main, had the main role in developing and designing this workplace-based assessment. And this process was also supported by different non-governmental organizations that working in education and training of its professional. And the process also advised by education and training advisors through a series of workshops and capacity building activities.
Okay, and where on the curriculum development cycle of surgical residency training in Ethiopia are you currently?
Currently, all the development phase of the curriculum is already completed, and the curriculum is approved and launched by the higher officials, by Minister of Education and Minister of Health, and it is already in the implementation status. And its implementation is closely monitored by each program, each residency program, and the educational development centers in each program was also closely monitoring the implementation. And the medical education unit in the Ministry of Health is also part of the system in monitoring the implementation of this curriculum and the workplace-based assessment.
Okay, and how did you structure the corresponding faculty development?
Yes, the corresponding faculty development activities was given for each residency programs, including the surgery residency programs, and the faculty development activities give emphasis on how the curriculum is structured and organized, and what are the main teaching learning approach for this curriculum. And especially due emphasis was given on the workplace-based assessment and how these tools and methods are using to assess the residents' performance in the real clinical environment. That was the main area of emphasis during the faculty development activities.
Dr. Karma, what were the good things and experiences?
We have been doing it for last 3 years, and then all along we have been getting feedbacks and from faculties and students. The students have said that the bonding with their faculties have improved. Why? Because they have number of opportunities where they interact with the faculty while they do WPBA. At the same time, the faculties have also mentioned that they're able to assess the student and understand the student better compared to the pre-WPBA era. So I think these are the good things at this point. And at the same time, the students themselves have come and also forward and said that they're able to build the confidence while they do the activities in their clinical life day-to-day time. So I think these are the few things I can share. Thank you, sir.
What were the challenges and barriers?
Yes, I think like any initiative, any project, there are huge challenges, and WPBA implementation also face few. We must be very honest. One thing is, every year we are seeing a high turnover rate of our faculty. Every new faculty that actually comes in brings in the concept, because in our part of the world, workplace-based assessment is a very, very new concept. And most of us have graduated through very conventional curriculum. So therefore, they often have a very difficult time to actually catch up what is this. And then, they really have a tough time actually. And then the second part is quite often there are critics who just come forward and say that, this is nothing we have been doing. It is just that you're recording. That's it. There's nothing different. These are the few things we have been, challenged with. But as through repeated faculty development program, through repeated workplace-based assessment workshops, we are bringing those critics to this side of the fence, and that way, we have been able to mitigate. However, challenge still remains. And the third last one is that there are still confusions and low level of awareness, especially among the new faculties. Yeah, thank you, sir.
Okay, and what is the way forward?
On the moving on forward looking, fast forward to 22-23, we are actually waiting for the evaluation report, which we are aiming to finalize by early 2022. And in everything goes, if the report comes in a very positive note, we would like to actually upgrade ourselves, refine this existing workplace-based assessment into further refinement in the form of interestable professional activities. And that's where the things will be more focused, things will be a little more clearer compared to workplace-based assessment. And in case the report is not so positive, yet it is in a good note, we are considering that we will include new tools, different set of tools in addition to the existing workplace-based assessment tools. So these are the few sort of 2 or 3 plans.
Ekulinet, can you tell us about the good things and good experiences that you had?
Okay, the good experience is the acceptance of this workplace-based assessment method by all stakeholders, including the Surgical Society of Ethiopia, as well as Ministry of Health, Ministry of Education, and other faculty members. And the second important good thing is the introduction and development of interestable professional activities. Really, this makes the assessment of workplace-based intangible and meaningful.
Okay. And what challenges and barriers did you experience?
The main challenge is a high turnover of faculty members, and most of the faculty members are very busy in their clinical work, and even lack of commitment or by some faculty members are the main challenge for the successful implementation of the program as per their design and development.
Okay. And what is the way forward?
The way forward is, I think it's continued to the faculty development activities, including orienting even the residents, the students, to be aware about what workplace-based assessment and what they are expected, and allocating maybe some of the essential resource for the successful implementation, and close monitoring of the implementation is very vital, and we have to plan to strengthen this close monitoring and generating some evidence by evaluating the program, the overall program at the end of 2022.
Okay. What is the perspective and the acceptance of the Surgical Society of Ethiopia?
Yes, I think what I can say is one of the most successful thing is acceptance of this workplace-based assessment curriculum and the interestable professional activity by the Surgical Society of Ethiopia. This is witnessed by the president and by some member of their association during their national symposium. So I think that is a very good thing and very important aspect for the successful implementation.
Okay, and now for something different. Could you explain very briefly implementation of workplace-based assessment in some professions like anesthesia?
Sure, yes, especially Ethiopia Anesthesia Association has developed and designed different workplace tools and disseminated for their programs across all the programs in the country, so that currently the anesthesia programs are using these tools and methods to assess their students in undergraduate level. I think this is a good experience other than the residents.
Now it's time to thank all of you for having us. Thank you, Professor Tejinder, and thank you, Karma and Ecolinet. We have reached the end of our presentation, and this paper is now open for your questions and comments. Thank you very much.
I believe Professor Matthias is online. So, sir, could you please unmute yourself and Chala can yes, we can see you. Hello, sir. Thank you very much for that enlightening talk with Dr. Karma and Ecolinet. And let me start off by asking you a question. We have workplace-based assessment here. We just introduced competency-based medical education. And one of the important principles of WPBA is the authentic learning environment. Simultaneously, we are introducing the student doctor concept. So I think that situation is handled, will be handled. But the two other principles of WPBA are direct observation of the learner and also giving feedback to them. Given the large number of students that we have in each class in our country, and seeing how resource intensive this is, how difficult will it be for us to, for the faculty to actually implement a workplace assessment on the ground? What has been the experience of other countries in this, and any suggestions for us to move forward?
Okay, thank you very much. I think that is one of the crucial points of workplace-based assessment, to come up with a clear plan for the faculty development activities. And when you talk of workplace-based assessment, you have to reconsider the idea of classes. Yeah? Workplace-based assessment does not take place in a classroom. It takes place at the workplace, as the name suggests, and that is the real interaction with the real patient in a real outpatient or inpatient setting. And I see that my co-author, Dr. Karma, also, obviously he wasn't given the microphone. Maybe you can turn his video and microphone on. Dr. Karma Tenzin of Bhutan. You saw him in the interview, and he just dropped a note in the chat saying one way Bhutan is peer coaching and peer assessment strategies, and also capacity development at faculty. Yeah. Once a resident is familiar with the concept of workplace-based assessment, one resident can give feedback to the other resident. Would you please turn on Dr. Karma's microphone and his video?
Dr. Karma, can you unmute yourself?
Thank you. Thank you. Thank you so much. No, just to supplement on what Professor mentioned, at least on dealing with the large number of students here in our Bhutan, what we do is let senior residents actually allow the WPB assessment of the junior batches. And that way, we are actually de-burdening our faculty members from getting, a huge, backlog of trying to assess the number of students. Thank you.
Thank you, Dr. Garma. Any questions here from the audience? Yes, sir. Dr. Super wants to ask a question.
How is Karma? Dr. Karma, can you hear me well?
Good afternoon, sir. Sir, it's a pleasure to hear from you, sir.
How are the postgraduates taking WPPA as how they accept it? And how has faculty accepted WPPA? And how do you make high-stake decisions for multiple assessments?
Thank you, sir. Thank you so much. I think that's a very critical question. We get this question asked many times on such platforms. The initial review when we did was where the faculties have said we are actually burdening them with extra papers, with extra need for extra administrative burden. But however, after nearly 3 years of experience, when we took informal feedback, the faculties, I must say, at least over 80% of faculties are now saying that yes, this is extremely useful. There is a very objective way of both teaching at the same time assessment. I think Professor Matthias did mention on this. And the students' part, again, initially they thought that we are already burdened with admitting patient, following up patient, OPT, OT, minor OT, clinics, etc. At the end, of nearly 3 years, what they are saying is, in fact, this was one of the best way to learn. They not only could build the technical confidence, but they were able to communicate well. They were able to relate to the patients well. I think that the humanistic part is also actually in development. So that's why if you look at, we had adopted 4 tools, and all these tools are very deliberately chosen because these 4 tools were focusing on the 3 domains of medical education: psychomotor, the attitude part, the cognitive part. So that way, both the feedback of both the faculties and the student after 3 years of implementation seems very good. Of course, as mentioned earlier, we are officially conducting reviews, and it is yet to come out on the official front. On the high stake or the low fidelity and high fidelity skills, what we are doing is we are encouraging our faculty members to choose the low fidelity skills for first year and second year. But however, as the student progress forward, we are saying this is how the high stake or high fidelity skills are actually chosen, and these skills are actually listed in our curriculum. First year, these are the skills. Second year, these are the skills. Third year, these are the skills. Thank you so much. I'll not take too much time. Thank you, sir. Thank you, Professor Sophie. Thank you.
I had a question. I had a question. Yes, Gurita, please come forward.
I think I saw one more question on the chat asking, when you get the senior residents assess the junior residents, how do you take care of bias from the residents? I think that's a good question. Karma, would you like to answer that?
Sure, sir. This is again a common concern. Even by the faculties, when we started, there was a concern. But since we have repeated, awareness and capacity building on the objective of the exercise, if we don't clarify the objective of the exercise, this is what exactly will happen. The faculty, the senior resident will, always have biasness. They'll say, oh, it's okay, let them be. But when the objective of the activity is clear, the residents are very, very objective in what they do, because they have come through the rungs, they have come through such exercise through the faculties. So therefore, at least in Bhutan, we have controlled this to a greater extent by explaining the objective. And when the students themselves, especially the senior students themselves, have undertaken these for quite a number of sessions, they understand the objective, and it's not very difficult to understand especially when they are 4th year. Yeah, so we have done that, sir. Thank you so much. Professor, would you like to add anything?
Yes, thank you, Karma. Thank you very much. I only want to add that the final exam graduation, of course, is not done by peers. This is done by the supervisors, by the department heads. So maybe that helps you to get over this concern. There was another question. I would like to know the age of entry into medical school in other countries. It depends on where you are, whether you are 12th grade or 13 grades of high school, whether males have to go into military service before they take up medicine. In our country, it is probably 18 to 19 to 20 years of age. Karma, what is it in your country?
Sir, we don't have one, but the scholarships given in Bhutan is 18 years. If you are not 18, your scholarship, your passport, official passport is not issued. So therefore, automatically, you have to wait for 1 year if you are 17. Yes, thank you.
The same is true for Ethiopia, speaking on behalf of Equilinet. Okay, so there's another.
So we have a question in the hall from Dr. Vinodha Shankar. Dr. Karma, it's for you. I needed your inputs on, you said about this empowering faculty by using faculty development workshops. So when the content was prepared, was it discipline specific or was it generalized workshop for all the faculty? That's one. Second is, was the content validated by some model, curricular review model? Because I was interested because you were following it in our academy. I wanted your experience based on it.
Thank you so much, madam. I think this is a wonderful question. On the faculty development related to WPBA, it's a very generic because we are looking at the process. We are not really looking at the content. However, the faculties actually, when we do the workshops, say example, an anesthesia faculty comes in, it is the anesthesia case that we actually deal with. If it is orthopedics, then we do this. So that way, automatically, they actually get the context also while we are focusing on the processes. And on the validation, we had Professor Matthias, coming with his team. And not only this, I think Professor Sope sir has also, been involved once or twice. And Professor Rege, I think the co-director of GSMC FEMAR, had also, I think visited once. And we actually also had Professor Purnima and Professor Rimal. That way, our validation is done by at least 4 or 5 countries, I must say. So that way, the output is seen in the form of faculty understanding the importance, getting that this is correct way. I think that itself shows that, yes, we have done it correct way. However, a lot of lesson to learn. Thank you, madam.
Thank you. Very inspiring. Thank you.
Professor, anything? Professor Matthias?
Is there still time? We are beyond the schedule. Is there still time for more comments on your side, Professor Techinger?
Thank you so much, Professor Matthias. We are running out of time, and it's time for our next session. The session has been very useful and very enlightening. Thank you so much.
Thank you so much. Thank you.
Thank you.
Thank you.
Our next topic is organizing the learning environment to enhance motivation and self-determination by Dr. Rashmi Kusurkar. Competency-based education treats students as equal partners in learning and requires them to be actively involved in setting learning goals, deciding the methodology, and performing self-assessment. The learning environment can play a major role in making this happen. So I invite Dr. Rashmi Kusurkar to share her views. I also invite our chairpersons. We have the same chairpersons, Dr. Ruchi Gupta, Dr. Anshu, and Dr. Tejinder Singh. May I please request the chairpersons to kindly introduce our speaker.
Thank you, organizers. So I will introduce Dr. Rashmi Kusurkar. She is the Associate Professor and Research Program Leader of Team Developing Students for Life. She's working at Amsterdam University, Faculty of Medicine, Vrije University Amsterdam, and Research in Education. She's a GSMC FEMAR from 2008, She's PhD in medical education at University Medical Center, Utrecht, and currently working as research program leader at Amsterdam UMC. And she supervised 12 Dutch PhD students with special areas motivation in education. And to her honors and awards, she's awarded the Dutch Medical Education Association Best PhD Award in 2014, Prize for Research in Medical Education in 2019, faculty and page editor on self-determination theory of motivation. She is also a visiting professor at the University of Indonesia. She is also executive committee member for Association of Education, Medical Education in Europe. She has a lot of publications to her credit, and we would like to now invite her for her lecture, Organizing the Learning Environment to Enhance Motivation to Self-Determination. Motivation and self-determination. Over to you, Dr. Rashmi.
Video.
Just to be clear, you're going to play the recorded presentation, right?
Yes, Rashmi.
Yes. Thank you.
Copy doesn't
Copy करी हुई थी वो कहाँ है?
Hello everyone, greetings from Amsterdam. I'm Rashmi Kusturkar and Associate Professor and Research Program Leader at Research in Education, Faculty of Medicine, by University of Amsterdam. I would really like to thank the organizers for inviting me to give this talk today. And my talk is going to be about how can we organize the learning environment in health efficient education to enhance motivation and self-determination. And when I talk about health efficient education, it means all teaching and learning, which is included for all kinds of health professions like nursing, physiotherapy, occupational therapy, pharmacy, etc. But I would like to start with who am I, why am I here, and why am I talking to you about motivation?
I'm sorry, but we can't see the screen.
From India, and I have specialized in physiology. Please wait for 5 seconds. I was teaching in GS Medical School college for 2 years. And during this time, I studied in education. I did my fellowship with GSMC Framework Vision. In education.
We can't see the presentation. We can only hear the presentation. I think I would like to take the opportunity to say hello to everyone from Amsterdam, since Dr. Sanjay Bedi is still uploading the presentation. So I would like to thank the organizers for inviting me, and I'm very happy to come back home and do my presentation about the work I have done, the questions that started in India, but the work that I have done in the Netherlands. So I'm very happy to see all the participants and lots of known people in the audience. I hope to get a lot of questions from all of you.
Hello everyone, greetings from Amsterdam. I'm Rashmi Kusulkar and Associate Professor and Research Program Leader at Research in Education.
We still can't see it. I'd like to thank the organizers for inviting me to give this talk today. And my talk is going to be about how can we organize the learning environment in health professions education to enhance more determination. And when I talk about health professions education, it means all teaching and learning, which is included for all kinds of health professions like nursing, physiotherapy, occupational therapy, pharmacy, etc. But I would like to start with who am I, why am I here, and why am I talking to you about motivation? By background, I am a medical doctor from India, and I have specialized in physiology from LTMC Science. I was teaching in GS Medical School College for a few years. And during this time, I wanted to do research in education. I did my fellowship with GSMC Famer Regional Institute, and I got really interested in education research. I wanted to do a PhD, but at that point in time, it was not possible to do that in India. Yeah, and when I was doing all this work, I was also doing faculty trainings for the university, MUHS, and I came across this batch of students in GSMC. I used to teach in the physiology auditorium, and there was this, I think in 2001 or 2000, I don't remember anymore. There was this cohort of students, and there were 10 boys who sat on the back benches. And after my lecture, they would come, they would surround me. They were all taller than me, and they would ask me very interesting questions. I used to love the interaction and the exchange, and I thought that these students are going to do really well in their first year. And to my surprise, some of them did really well. Some of them did not give the performance that I expected them to. And I could see the motivation of some of them actually going down during the year. This really fascinated me and triggered me to think about why does this happen? That someone who comes to seems to have similar type of level of motivation does not perform in the way that I expected them to. So this was my inspiration to do research on motivation. After 7 years of working in GSMC, we moved to Amsterdam because my husband took up a job in Amsterdam. And then I got the chance to apply for a PhD. And I was lucky to find a PhD position with Professor Ola Tenkaita and Professor Gerda Grosse in 2008. Many of you might know Professor Ola Tenkaita's work because he's the guru of interestable professional activities, EPAs as they are called. And they both really encouraged me, and they gave me a choice on what I wanted to investigate. And then I decided to take up these questions which had fascinated me during my practice. So I took up burning questions from my practice for my PhD research. And that's how I completed my PhD thesis on motivation in medical students in 2012. Today I'm going to present to you the work that is done by myself and my group on the topic of motivation in health professions education. So I have twofold objectives for this talk. The first objective is to provide a research-based perspective on how and why motivation is important in health professions education. And the second objective is to provide suggestions on how we can organize health professions education learning environment using self-determination theory principles to enhance student motivation. Before I go into what we found in our research, I would like to take a step back and think about why is it important to focus on student motivation. I think many of you might know the answers. The first is student motivation has been shown to be associated with a deep learning approach. And deep learning approach means that you want to learn something because you want to understand it and not just rote memorization, which you want to present in the assessments. It is also associated with higher study effort, higher academic performance, higher commitment, lower dropout, and more positive well-being. And from my point of view, I find the positive well-being the most important feature of or association of motivation, because currently the burnout among physicians and among medical students and residents is so high that we really need to give this attention. Also, there is less exhaustion from study. So the last 2 points for me are very important. Then I would like to talk about where I started my study. So I started looking at the strength of motivation for medical school, which was based on the quantity of motivation. And I had 2 articles in 1 year or 1.5 years. In the first article, what I found was being older, being female, and having a bachelor background. That means not directly from high school, but when you do a bachelor's in something and then you join medicine, that predicted a higher quantity of motivation. And in the second paper, I investigated the concurrent validity of measuring the quantity of motivation with strength of motivation for medical school scale, and I compared it with academic motivation scale. Now I had 2 articles in 1.5 years, but I was here. I didn't know where I want to go. Why do you think this happened to me? So the point was that though I had 2 papers, I was not able to explain what I have seen about motivation in my teaching career. I was not able to explain it on the basis of quantity of motivation. So I was very dissatisfied. And at this point in time, I took a step back and started looking at theories of motivation and trying to understand what was happening around me. Then I stumbled across the self-determination theory of motivation, which is founded by Professor Dr. Edward Deci, who is on the right, and Professor Dr. Richard Ryan, who is on the left, from University of Rochester, New York. Self-determination theory is a macro theory of human motivation, and it can be applied across contexts. It is not only for education, but you can also look at it, use it to understand interpersonal relationships. You can use it to understand motivation for sports, for well-being, etc. And what is the main crux of self-determination theory is that it looks at the quality of motivation or the type of motivation. That means it looks at why do you do what you do. The why question is important. And self-determination theory, it puts motivation along a continuum. I'm going to take you through the continuum. You don't need to worry about all the terms. Now, in the quality of motivation continuum of self-determination theory, there is intrinsic motivation on one end and there is a motivation on the other end. Let's start with intrinsic motivation. So if I will come to this continuum again later. Let us start with what is intrinsic motivation. Engaging in an activity out of genuine interest, like you see what the baby is doing here. The baby is playing with the box. And he really does it because he's very, very interested, curious about the box. So if you engage in an activity out of genuine interest, then it is intrinsic motivation. What is extrinsic motivation? Engaging in an activity to please others or because of pressure from others, like you see in this picture, because my mom told me to do this, or out of guilt or shame. Example, because I would be a bad example for my younger brother if I don't. Or for money, fame, appearance, because I want to own a BMW, for example. Or engaging in an activity for a reward. So intrinsic motivation is about genuine interest whereas extrinsic motivation comes from internal or external pressure or for rewards, money, fame, appearance. Now we come back to the quality of motivation continuum again. So here you see that intrinsic motivation is on one end of the continuum and amotivation is on the other end of the continuum. So let me give you an example of medical students. If a student joins medicine because he or she is really genuinely interested in the subject and in helping people, that is intrinsic motivation for medical study. If someone joins medical study because he doesn't know what else to do, or he has no direction or no drive, that is called amotivation. So lack of motivation is amotivation. And then if you look at extrinsic motivation, it is not one entity, but it is classified into 4 different types of regulations depending on where it originates. So let me come to the one on the most left side, and that is external regulation. Now, if a student joins medical education or medical study because his parents force him to, that is external pressure, or because he or she wants to have a lot of money and prestige in the society, that is external regulation. Now, if the student joins the medical study because he or she feels internal pressure, so there is expectation from the family, but he also feels himself the pressure that I want to do it to please my family. So there is internal pressure as well. That is called introjection or introjected regulation. Then it's the next stage and phase, and that is called identification or identified regulation. And that is when a medical student joins medical study because he finds it very important. So he may or may not like it, but he finds it important to help people or whatever. If the person joins medical study because of some external reason, but over the years it has become part of his self-identity, then it is called integrated regulation. So you see that on this continuum, intrinsic motivation is the most self-determined, that is determined by the self type of motivation, and external regulation of extrinsic motivation is the most non-self-determined type of regulation. Now, self-determination theory initially started talking about intrinsic versus extrinsic, but over the years, it is now more about autonomous and controlled motivation. What is autonomous motivation? So they have put intrinsic motivation and identified regulation together. So any motivation that comes from genuine interest or because you personally endorse the importance of doing something is called autonomous motivation. On the other hand, if someone is doing something because of internal or external pressure or for rewards, it is called controlled motivation. Let me give an example of what is my motivation to give this talk today. So I would say that I'm here today because I have intrinsic motivation for this topic. I love this topic. I have done my PhD on it. I continue to do research on it. So I'm here because of my intrinsic motivation. I'm also here because of my external regulation. So my boss expects me to do this kind of work, these kind of talks, so that I have a great researcher profile. That is why I'm here. That is external pressure. So I'm here because of external regulation. I'm also here because of internal pressure. I'm here because I expect myself to do this because I want to reach a professorship, and for that I need a certain researcher profile. So I'm here because of internal pressure, that is introjected regulation. I'm also here because of identified regulation. I really find this important. I want to take the message of stimulating student motivation. I want to take it forward to as many teachers, as many students as possible to bring about a change. So I find it very important. I personally endorse this importance, and that is why this is identified regulation. I'm also here because over the years I have done these talks and workshops for so many people that it has become part of my identity. Talking about self-determination theory and motivation has become a part of my identity. So I'm here because of integrated regulation. So you see, all types of motivation are present in me for doing a particular activity. But there is always a predominant type of motivation. So if I put a hand over my heart, I would say that I'm here because of my intrinsic motivation, because I love this topic. So all of you would be having, for every activity, all types of motivation. But what is important is what is the predominant type of motivation that you have. Now, why is motivation so interesting? I find it interesting because it is not a stable entity, it is dynamic. It means that autonomous motivation can change to controlled motivation, and controlled motivation can change to autonomous motivation. With the right teaching practices, a student who comes in with autonomous motivation for medical study, with the wrong practices, you might be converting it to controlled motivation with a focus on assessments, for example. And on the other hand, a student coming in with controlled motivation, with your inspiring teaching and the right ways of learning and teaching processes, can move someone from controlled motivation towards autonomous motivation. So as teachers, you have that power. Now, the other thing about self-determination theory that I like is that it doesn't only tell us that it is possible to mold motivation, it also tells us how to do it. So how can we stimulate autonomous motivation among students? It talks about 3 basic psychological needs that need to be fulfilled in order to have someone autonomously motivated for something. And the first need is the need for autonomy. What is autonomy? Autonomous motivation can be enhanced by supporting autonomy, which is feeling of choice in action. That means the students feel that I have a choice in learning, in the way I'm learning, how I'm learning, at what pace I'm learning. So they need to have a sense of autonomy. The second need is the need for competence. So if the students are autonomously motivated for something, they need to feel capable of doing it. So they need to feel competent of learning. And the third need is of relatedness. So relatedness or emotional support by peers, that if that is supported, then a person can be autonomously motivated. Now I'm going to talk a little bit about the research that my group has done on motivation. So what are our main findings? This was a review that I performed very early in my PhD. And I looked at how has medical education studied motivation among medical students. And what I found was, so I looked at it through the lens of self-determination theory, but all the articles that were included were not necessarily using self-determination theory. And what I found was that motivation performs as a dependent variable, which means that motivation is influenced by influencing factors. So these are the factors that you see on the left side. And motivation also performs as an independent variable. That means that it has outcomes. So it leads or it influences some variables. And these variables you see on the right side of the screen. Let me start with what are factors that influence motivation. And what I found was there are 2 types of factors. One is variables that cannot be manipulated, and the others is variables that can be manipulated. So among variables that cannot be manipulated were age, gender, ethnicity, socioeconomic status, educational background, year of the curriculum, and parent and teacher support. I'm not going to go too much into details on this. Variables that can be manipulated, I was able to look at them through the lens of autonomy, competence, and relatedness. So examples were autonomy support. Anything that supports students' choice in learning helps to stimulate their autonomy and hence their motivation. Type of curriculum. So a curriculum which supported autonomy also was associated with motivation. Extent of responsibility. So giving higher patient responsibility to a student was stimulating motivation. The feeling of self-efficacy, which led to competence. In selection procedures, getting selected helped them with feelings of competence. Assessment helped them to feel competent. Rewards helped them to make, rewards were actually negative on motivation. And knowledge acquisition and perceived task value helped with motivation. And in relatedness, early patient contact and well-being were the ones which stimulated motivation. Motivation in turn was responsible or associated with a higher academic success and performance, learning and study behavior, choice of medicine as a career. So why would you choose medicine as a career? Specialty choice, which specialty you would choose, and intention to continue medical study. So from the review, we found that motivation was an important variable in health professions education. Then the next study that I did was on motivational profiles among medical students. So as I showed you in the earlier continuum slide, we have all types of motivation. So I looked at what was the total, not total, but a combination of autonomous and controlled motivation in a student. And I found that there were 4 motivational profiles among medical students. The first profile was high intrinsic. So here I used intrinsic motivation rather than autonomous. High intrinsic, low control. 30% females in my population, in my student population, and only 15% males were in this particular profile. And this profile means that you're genuinely interested in medical study or practice. The second profile was the worst profile, which was low, sorry, this was not the worst, low intrinsic, high control motivation, and 28% of females and 41% males were part of this profile, and this was mainly related to expectation of high income. The third profile was high intrinsic, high control, and here 25% females, 27% males, and this was related to having both interest and expectation of high income. And then only 17% females and only 17% males in low intrinsic, low control. This is the worst profile, and they were not particularly interested in medicine. So what you see here is that according to self-determination theory, the best profile is having high intrinsic and low control. But there were only 15% males in this profile. And the worst was low intrinsic, low control, and we had still 17% of the student population in this profile. Now you would think, why is high intrinsic, high control not better than high intrinsic, low control? That's because control motivation has a hampering effect on intrinsic motivation. So if you have high control, then what we saw was, when we looked at how are these related to outcomes, and what we saw was the high intrinsic, low control profile, which is the profile which is supported by self-determination theory. They had higher deep study strategy, they had higher self-study hours, higher grades or performance, lower surface study strategy, that means rote memorization, and lower exhaustion. Now that was the only difference between the high intrinsic low control profile and the high intrinsic high control profile. High control profile also had deep strategy, self-study hours, performance, everything, but they were poor on well-being and they had higher exhaustion. And then in the second study on motivation and performance, what we found was that autonomous motivation, which you see on the left side, is indirectly related to higher academic performance through good study strategy and more study effort. It is not directly related. Then we decided to look at how has motivation been given attention or ignored in medical curricular reforms. This was also a review, and we reviewed all the important curricular trends that happened in the world and looked at whether motivation was given attention. And you can clearly see here that except the experience-based model, which looked at motivation, the others either ignored it or their attention was implicit. They only looked at the cognition part, that means the content of what needs to be studied, and the metacognitive regulation, that means what should be the way in which it should be studied or how should students study, without any attention to how you should motivate students. There's a big gap in in medical education curricular reforms. Then we wrote 2 application papers. One was an AME guide on self-determination theory. How can we understand teaching and learning processes in medical education? And the other one was 12 tips to stimulate intrinsic motivation in students in the classroom. So basically, what I have done with my group is that I continue to investigate the medical education continuum. We start with high school students who decide to apply for medicine. undergraduate students, postgraduate students or residents, and practitioners for continuing professional development. I would first like to talk about my PhD student Anup Wouter's work. And she looked at effects of medical school selection on motivation of the student population and applicant pool. So when they came into medicine, we looked at, did they come in the Netherlands? There is a very special phenomenon. Students are admitted on the basis of weighted lottery. So depending on your high school grades, your GPA, you get there is a lottery procedure that happens, and then in that you get selected for admitted to medicine or you don't. So there were some batches, cohorts of students in which some of them were selected and some of them came in through lottery. So we were able to make a comparison. So what we found was that when we moved from lottery to selection, in the student population, we found that students who came in through selection processes, they did not have better quality of motivation or engagement in the study or performance than the ones who came by lottery. The second finding was that the type of selection procedure, whatever you apply, does not seem to be related with motivation, engagement, and performance. This was the student population. Then we looked at what happened in the applicant pool. That means what happened at the high school level when you had a selection procedure. So selection seemed to temporarily stimulate student motivation, and it went down after 6 months. The effect did not stay long. Selection seems to stimulate strategic behavior among applicants. That means they try to find out which is the best place, which selection procedure can I crack. So they try to game the system. And the last but the most disturbing finding was that diversity and accessibility of medical education was compromised because of a selection process. So students who were first generation university students who had a lower socioeconomic background, who came from students with parents with lower educational background, they felt that their chances to get through a selection procedure were lower than the others, and that's why they did not apply. So this was a very disturbing trend that we found, and this received a lot of attention in the politics and in the media. The second PhD student, or the next thesis that I want to talk about, is the PhD thesis of Ulviya Isik. And we looked at motivation and academic performance of ethnic minority medical students. And what we found was, we compared them with white majority Dutch students. And what we found was that factors that negatively influence motivation and academic performance is an important factor is a lack of role models. So they don't see anyone from their own ethnic background or from their own ethnic minority background as a role model. They don't see them on the work floor, so they are not sure that they'll be successful in their medical study. And they feel other due to their ethnic background because they are treated differently. What we found that the kind of support that they need is creating more awareness about diversity and a support group, having visible ethnic minority role models, facilitating support in networking, and providing guidance in communication skills, because they did not come with a network in the medical field. They found it difficult to cope up. So you can compare this with students who come from rural areas in medical schools in India, or students who come from non-medical families. They find that would be the population to compare with ethnic minority students in the Netherlands. So they need to have visible ethnic minority, or you can say here the kind of people they need to see them more successful people from their type of background. They need to support in networking, because networking is important in getting through medical study and on the work floor, and providing guidance in communication skills, because they might be used to having a different type of communication than what is expected in medical education. Then I would like to talk about the thesis of Cora Fisser, and here we looked at the affective component of interprofessional education. And we found that taking the patient's perspective and motivation for medical school, it explained 16% of the variance in teamwork and collaboration. So motivation was important in interprofessional education. And there was a ward, an interprofessional education ward, which was constructed. And in that, what we found was that this IPE ward offered them the experience of interdependence of professional roles and responsibilities, and it made clear to the students what each profession adds to the care of a patient. So it was a wonderful way of motivating them for interprofessional education and collaboration. The next study that I would like to talk about was the students in our medical school, or rather residents. They set up something called a learner-centered student-run clinic. Now, in this learner-centered students and junior students, that means we have 6 years of medical study, 1 year each. And you had students from 6th year, 5th year, 4th year, 3rd year, 2nd year, 1st year. They all work together as a team and they handle patients on their own, but under the supervision of a medical doctor. And what we found in this particular educational innovation is that it was motivating for students because it provided them autonomy, as I talked about before, autonomy in and responsibility for patient care, feeling of competence because they help patients, and they felt relatedness with peers and faculty, and feedback from patients. So this particular learner-centered student-run clinic was a very successful innovation for stimulating student motivation. We also studied e-learning on antibiotic prescribing. Does autonomous motivation play a role in the participation? And what we found was that residents who report higher autonomous motivation for education on antibiotics are more likely to engage in an e-learning module on the subject. So autonomous motivation was related to participation in e-learning. Then then I would like to talk about the thesis of Stephanie van der Burgt, and she looked at how to sustain the motivation of medical specialists for medical practice. What we found was there were 4 different motivational profiles. And if you remember the earlier motivational profiles that I showed you, here we use autonomous motivation instead of intrinsic motivation. So she found similar profiles, except she did not found any high controlled measures. So she found high autonomous low control, high autonomous moderate control, moderate autonomous moderate control, and moderate autonomous low control profiles. So we found that among medical specialists, the control motivation was never, the autonomous motivation was never low. It was either high or it was moderate, but otherwise they were similar to the other profiles. She also found that autonomy and competence were most important for work and lifelong learning motivation, because we looked at lifelong learning motivation in this particular project. Basic needs supporting factors, one of them, important one, was good communication with colleagues that help specialists remain motivated for their work. And basic needs frustrating factors were mainly tasks that distracted from patient care. So the specialists came into their job for patient care, and all kinds of administrative tasks and get running into difficulties, technical difficulties with the computers or with the patient folder system, etc. That was very distracting for them, and that if it happened on a continuous basis, then it became demotivating for them. And the way they coped up with demotivating factors was that they tried to get back the sense of autonomy in their work by being able to arrange their own schedule, by being able to take the right decision for their patients, and by reinstating their feeling for autonomy, and through relatedness. So if they had good relatedness at their department, they really missed it that they were not able to talk to colleagues and they were not able to share problems. So the coping narrative was always the relatedness, which they would derive from their personal situation at home. So if I look at the summary of findings across the health professions education continuum, we found that selection for medical education did not yield any gains in terms of student motivation. 4 motivational profiles were found consistently in health professions education students and health professions. Control motivation was associated with poor learning, performance, and well-being outcomes. Organizing curricula to support basic psychological needs satisfaction helps stimulate autonomous motivation for learning. Frustration of basic psychological needs in the work or learning environment was consistently associated with controlled motivation and poor well-being outcomes. And the last one is coping with factors negatively influencing motivation involves organizing things for basic psychological needs satisfaction. I come back to the basic psychological needs: autonomy, competence, and relatedness. How can we fulfill these needs in our curriculum? So we come to how can we enhance autonomous motivation? And the first need is the need for autonomy. So what are the tips for stimulating autonomy or satisfying autonomy among students? The first tip is to provide learning responsibility to students. Transferring responsibility for learning from teachers to students helps in feeling autonomy, and which means that we ask students to come up with learning objectives, them to take the responsibility for learning, them to decide how to do things, when to do things, and at what pace to do things. So transferring the responsibility from the teacher to the student helps in satisfying feeling of autonomy. The second tip is to have an authentic learning experience. So as you looked at the earlier, what I presented earlier in the learning centered student run clinic, students actually had authentic learning experiences by actually working with patients. So the more authentic you make the learning task, the more autonomy the students feels in his learning, because he knows what is the importance of this for the future practice. The next step is to provide choices in learning. So this is one of them was to give learner responsibility. On the other hand, you can also give choices on, let's say, let's handle this particular topic by having a debate or having a role play or having a quiz. So you can ask students which of these choices do you like. Maybe the next lesson or next lecture we can arrange in this particular way. So the student feels that he or she has a choice in how he or she is going to experience the learning activity. The next step would be to use supportive language. So instead of using you have to do this, you must do this, you can use words like you may do this, you can do this, you could do this. So use of may, can, may, can, could instead of must, have, and should helps in stimulating the feeling of autonomy. The next point is to have trust in students. So when you give students to make them feel that they have autonomy, you need to trust that if you tell them something, they are going to do it. So trust forms a really basic, a backbone of autonomy. You need to be able to have the trust in students that they will do what they are asked to do. So giving the feeling of trust is important for satisfying the need for autonomy. And the last tip is to give patient responsibility. So you can see that these tips actually overlap each other. So giving patient responsibility also is related to giving learning responsibility. It is related to giving authentic learning experience. So giving patient responsibility to students to really handle patients on their own, that stimulates feeling of autonomy because they see it as their choice to have come into the medical study and they see the relevance of what they're doing. So giving patient responsibility gives them the feeling of autonomy because they feel that the teacher trusts us and is giving us the chance to do something on our own. The next need is the need for competence, and the tips for stimulating competence would be constructive feedback, but the feedback should not be on the person but on the task. So instead of saying that, oh, great guy, great, just saying you are good, the feedback that needs to be given is not person specific but task specific, that this task you did well on this points and you could improve and so points. So make it task related feedback and not person related feedback, because person related feedback can come across as threatening and it doesn't help anyone. So telling someone that, oh, I don't like your way of speaking, or your voice, is not something that a person can change, or I don't like the way you look. That's not feedback. And the feedback should not be on the person, but on the task and how he or she is performing the task. The next tip that I have for you is about giving milestones of responsibility. So I said that feedback should be constructive. Does it mean that you cannot give corrective feedback? No, that's not what I mean. Does it mean that people shouldn't try difficult tasks? No. My suggestion would be that if a certain student finds a task very difficult, you could break down a difficult task into smaller steps of competence. So you could break it down into different milestones. When milestone 1 is achieved, the student feels competent to go to the second milestone. When milestone 2 is achieved, the student feels competent to go to the third milestone, and so on. So if there is a difficult task for the student, you need to break it down into smaller milestones of responsibility, but still give responsibility. The next tip that I have is providing compliments. So many times we give feedback to correct students, to help them, give constructive feedback, but we forget to give compliments. And giving compliments can go a long way in bolstering students' confidence and competence. So I would really encourage you to give compliments when students do their work well. And the fourth tip is on the right level of challenge. So it is important that students don't get tasks which are too challenging for them. Then it becomes, then it stimulates feeling of incompetence. It should also not be a very easy task, because that doesn't challenge them to do anything beyond their, which is up to their capability, and then students don't really learn. So adjusting the level of challenge to the capability of the student helps in furthering his feeling of competence, and also introducing a little bit of a challenge to go further than they think they can. The next need is the need for relatedness. And the first tip that I have on relatedness is about explaining the relevance of the activity for practice. I said before, I gave an example of the Krebs cycle. So I think the students don't know why they are learning, or they're not able to connect it to practice. It is difficult for them to be motivated to learn it. So I would really encourage you to explain the relevance, the clinical relevance, or future practical relevance of the learning activity that they do. The second tip would be establish a relationship or a group feeling. So if you're a tutor for a small group, try to establish informal relationships between the students and between the teacher and the students, so that there is a feeling of group or peer learning, or a sense of belonging to the learning environment. And that can go a long way in stimulating autonomous motivation. The next tip that I have is about accepting students' feelings of negative affect. So sometimes, let's say the next day students have an exam. So on a particular day, they don't feel the capacity or the bandwidth to be able to listen to what you are teaching. So I think having a discussion about it and accepting when the students say that they have they are very stressed and they don't want to do this today, just listening to them and having a patient ear, and then giving them maybe your own examples when you are a student, that helps in students feel heard and understood, and that could help them to actually be able to concentrate on the task at hand. So I would say that don't deny students' feelings of negative affect, but actually accept. The last tip that I have on relatedness is to do with stimulating group responsibility. So when you work in a group, one of the things that you can do to bolster relatedness is for them to feel responsibility towards the group activity. Because in a group, every person has his or her own role, and if they don't do their role properly, then the group learning suffers. So giving them the idea of group responsibility and really teaching them how to rise up to group responsibility can really help in creating an environment of relatedness in the group, and this can really stimulate their autonomous motivation. These were my tips on the 3 needs. I've come to the end of my talk. So my key messages from today's talk are: giving importance to student motivation, or paying attention to students' motivation, is very important because it is related to deep learning approach, to higher study effort, to better well-being and higher study performance. The way in which you can do this is by stimulating autonomous motivation, and this can be done through providing fulfillment of the 3 basic psychological needs of autonomy, competence, and relatedness. So as teachers, we have power in your hands to mold your students' motivation from control to autonomous or sustain their autonomous motivation. With the right practices, you can move students from controlled motivation to autonomous motivation. And with the wrong teaching practices, you can have the opposite effect. So as teachers, I would really encourage you to help students be autonomously motivated. I hope that you will take these messages into your teaching and learning practice from today. If you would like to follow my videos or blogs or podcasts, you can. These are the links. And what I would like to say at the end is that I have now been doing research on motivation for the last 11 years, and I have found not 11, it's actually 13 years, and I have found this to be a very exciting path. But there are still so many things that I still need to study with my group. And I hope to be studying this topic for a long time in the future. And I would like to thank my research group. Not everyone is present in this picture, but everyone from my research group I would like to thank for their support and for everything that they have added to piece this puzzle of motivation together using self-determination theory. Thank you so much for a patient hearing, and I would really love to answer your questions. Thank you very much.
Thank you, Rashmi. Thank you, Rashmi, for taking us through this remarkable journey of your research on motivation. It's heartening to see that when a child is born, they are buzzing with questions. And I don't know what happens to our system where we kill the joy of learning.
Absolutely.
So those steps are very valuable for all of us. The question I have for you is, how do we design assessments so that learners can be more autonomous?
That is exactly the research that I'm working on right now. I'm doing a review of, I'm trying to find in the literature, are there assessments which can stimulate motivation? So I can answer this question in about 2 years, I think. Because right now, the way our assessment systems are structured, it really kills student motivation. And students are very, very particularly interested in preparing for exams. So even when you're teaching, they ask you, yeah, but is this going to come in the exam? So that's really, it's a system. We destroy the motivation right from school, I think. We have to start working from the school level.
So there's a question from Dr. Saoji.
Hello, sir.
And it's always nice to listen to you and give a different perspective on the great work that you're doing. Motivation is really an important topic, and we can really do wonders if we are able to encourage students and get most out of it. My point is that formal environment which is there, academic environment, it is easier said than done. And then, of course, in most of the institutes now, we have a so-called mentor-mentee system which is there. And the mentor is supposed to be maybe guiding or maybe providing for the needs or maybe motivating the students and academic as well as extra academic needs which are there. In majority of the places, again, it's on paper. So do you have any suggestion how we can really make this mentor-mentee system a little more effective?
Yes.
And in a formal way, yes, what all things you said, but in an informal way, in a mentor-mentee system, which is, as I said, it's there, it's some of the requirements, but not as effective as probably it ought to be.
Yes. So I would like to, first of all, direct you to the work of Dr. Shubha Ramani. She has done work which talks about if you are in mentoring relationship, mainly about feedback, and relationships are key to feedback being received in the right way. And the same works for mentor-mentee. And we actually investigated, and right now we have submitted the article. It was about mentoring initiative in the AME, the Association for Medical Education in Europe. And what we found was that the relationship is the key. And I'm also a tutor for first year medical students. It is important to build a relationship with your mentee. If you have an informal and a trusting relationship, you can do wonders for the mentee. And the other thing that we found was when you have choice in who can be your mentor or mentee, this system works better than formally assigned mentor-mentee relationships, because formally assigned ones come more, there is no choice in it. So there is the students or the mentors don't feel autonomy in how they are allocated to each other. So relationships which are based on role modeling, trust within the relationship, and trying to make it a more informal rather than formal relationship really helps the mentor-mentee system. I am now currently doing mentorship for many students. And what I see is that students really want to understand things about professionalism and how to move around in the medical circles, etc. And that you can really do through mentor-mentee relationships and through role modeling. So you're also a role model always in a mentor-mentee relationship. So paying attention to these aspects is important. And according to, if I put self-determination theory in there as well, it is the relationships which are the key.
Okay. Hello,
sir.
Good key messages. I have only one question to you. See, in last 20 years, we have seen because of the needs coming, most of the students are motivated and directed whole energy towards appearing for this need. And their motivation to go into the clinical wards and really go into the clinical competence becomes little weak or less. How do we motivate them to this clinical?
Yes, so I presented the work on selection exactly for this reason, because we feel that when we are selecting, we select the best students, the most motivated students, but that's not so. Because when we have a selection process in place, students try to work only for the selection and they don't really try to learn. So they are always in a system where they are preparing for assessments, preparing for selection, preparing for specialty selection. So this system is a vicious cycle. So we really need to look at it with fresh eyes. For example, the programmatic assessment. So actually India is now embarking on its journey with competence-based medical education. Now in the West, we are more towards programmatic assessments where we have got rid of all the grades that we give students. So there are no marks that they get for their clerkships, but they get only feedback. And the feedback is in a very narrative format. So when we move students away from grades, from numbers, from assessments, that is when we get actual learning. So I think if we want to really, what we also do in the Netherlands is people are chosen for specialty, for specialization, not on the basis of their GPA or the marks that they got in their exams or in an entrance test. They actually have to do, let's say, 6 months training in a certain ward, which they're the specialty that they're interested in, and they're observed, and the specialists actually see, do they work well in a team? And on the basis of that, students are selected for their specialization places. So I think the system needs a big revamp to be able to take the assessment-based learning that is happening right now out of the system. That is when you can get the real interested students prospering in the system, I think. So as teachers and as policy people, we have, and as leaders in medical education, we have lots of work to do.
So I know there's time. I'll just one small thing. Sorry.
Yes, sir.
Yeah. Again, Dr. Sauri here. Just one small point or rather question. Can this all be extrapolated to faculty motivation? Because
absolutely,
that's an equal challenge which is there.
Absolutely, sir. So one is we don't give students enough autonomy. On the other hand, we also don't give faculty enough autonomy. So faculty has less chance to decide how they want to teach, what they want to teach, how they want to interact with students. Everything is prescribed. So I think building in how you can support the needs of faculty is very important for faculty motivation. So it's the same 3 needs which the faculty need to be supported as well, so that they can be motivated for teaching. So this theory can be applied to many different contexts, and it is very, very relevant to faculty motivation as well. We have done work in faculty motivation as well.
Rashmi, I see you have been answering questions on the chat already. So please continue to do that. You've given us a lot of food for thought, which we need to really sit and chew on. And it's time for lunch for us. So time for some food for sustenance also. Thank you so much for that excellent talk.
Thank you so much. And people who have any more questions for me, please email me your questions and I will respond to them. And you can share my PowerPoint with people if you like after the conference. So I'm absolutely fine to share everything. Thank you so much. Thanks for inviting me.
Thank you, ma'am. It was a wonderful talk, and I thank the chairpersons for the session too. I would request Dr. Vivek Sauji to please come forward and felicitate our chairpersons. Dr. Anshu.
Avinash, your photographic skills.
Face, sir, is the camera. This side, this side. Dr. Ruchi.
She will post it on the Facebook.
I will post only Anshu photo.
Dr. Tejinder Singh.
That's the special one.
Wow.
I would also like to felicitate Dr. Sanjay Bedi, who has been very helpful to us throughout these sessions.
Whatever class for Sanjay.
That's all personality.
Both the senses.
Thank you, everyone. Now we'll break for lunch for half an hour.
Jamkar sir, we can see you on the screen. Just checking the audio. Are we audible?
Yeah, yeah.
Yes, sir. Thank you. You are seen and heard. Thank you.
I think me and Dr. Payal are only from outside, na?
Yes, sir. You are joining online.
So where are you, Dr. Jamkar? Are you in Goa?
Expert judgment.
Subjective.
Otherwise, anybody moving beyond around is seen there.
सच्ची में गोवा में क्या?
नहीं, this is a standard Zoom background.
नहीं, but all live. Technology.
Technology, yeah. Actually, NCHPE should have created a background so that we can put it behind.
Am I audible? Am I audible?
Yes, yes, yes.
So actually, now we won't use these mics. So आगे आ जाओगे तो ज़्यादा अच्छा रहेगा.
अच्छा,
Is my mask creating a problem for anyone?
No, can remove that. Fine.
So if you take it out, then it will be clear. But you want to
Where is Anand?
Sir, I'm here, sir.
Yeah. Because I haven't seen you.
Yes, sir. I agree. I understand that. You only heard the voice.
Yes. All the sessions were technically very sound. Thanks to Sanjay.
Some of the best people actually. You know, all of these people
So there is almost essentially
I spoke to her. It was a program. I will make it.
I will not send the video. I think we should start 1:45.
I think Payal will join by the time. She's joining.
Tribert's speech was very nice, huh? Avinash.
Yeah, very nice. Even that Lambert
Motivation.
yesterday,
Motivation was also good.
Yes, yesterday Lambert's talk was also very good.
morning में बैठ के भी अच्छी थी. For example, she gave
Cummings,
bridge one.
Structure it around, folded around.
This is a good concept.
It was my batchmate.
Yeah.
Which be strict.
उसमें गोवा जा रहे थे.
You can manage some of this.
I think we'll start. I will join.
Should we start, sir? Good afternoon, all. So, we welcome you to the panel discussion on subjective judgment in CBME. The moderators for the session are Dr. Anand, he is Professor Respiratory Medicine, Health Department of Medical Education, KMC Bangalore, and Dr. Chetna Desai, she is Professor Pharmacology, BJ Medical College, Ahmedabad. Welcome you, ma'am and sir. And may I please request the moderators to kindly introduce our panelists. Thank you.
Thank you. Welcome to this panel discussion on expert subjective judgment in competency-based medical education. And we know that CBME seeks attainment of observable abilities by the student in a centered manner. And we also know that assessment drives learning. And in CBME too, the assessment is a very good strategic tool to, enhance learning. There has been over a past decade or so, what has happened is that the assessment has moved from the subjective assessment to a preponderance to the objective assessment. And the objective assessment, as we know, is a judgment where there is no interference or very little interference or even potential interference of personal opinions or preferences or modes of observations, etc. The debate regarding subjective versus objective assessment continues. And it is a fact that objective assessments are usually done under very controlled conditions. But however, what happens when the student or the learner actually faces the real life situations, we do not really know. So hence this topic today. And however, at this outset itself, we would like to clarify a couple of points. First, that this discussion will focus mainly on expert subjective judgment as against just subjective assessment. So this can be a bit confusing, I'm sure, but we are confident that as we progress in this discussion, we'll be able to clear out several of our confusions with our esteemed panelists. And also, this discussion will focus on assessment of skills and would not really dwell much upon knowledge testing. So there are several questions that are plaguing us at the moment. Like, for example, what are the differences between subjective and objective assessment? Is objective assessment really as good as it is thought to be? What are the myths associated with subjective assessment? What are the barriers to subjective assessment? Okay. And should we really abandon subjective assessment? And if we really want subjective as well as objective assessment, what should be the, the proportion and how it should be done? So many of these points are there for us to ponder. And for this purpose, we have our esteemed panelists, whom I would request Dr. Anand to introduce. Thank you.
Thank you, Chetna Madam. Good afternoon to all of you. It's my privilege to introduce this, what should I say, the galaxy of stars on the panel that we have got for today's discussion. Let me be the person who is sitting on the extreme left to me. I start with Dr. Avinash Supe. Not that any of these panelists need an introduction, but Dr. Avinash Supe is Emeritus Professor Surgery, Medical Education at my alma mater, which is the SGRDUHS Medical College, Mumbai. He is a recipient of the BC Roy Award. Welcome to you, sir, to this panel. Next, we have Dr. Vivek Sahoji. I think we have very pleasant memories that when I did my first workshop together, it was with Dr. Vivek and Dr. Avinash, I think, who guided me in this journey. So Dr. Vivek is a surgeon. He is currently the Vice Chancellor of KLE Academy of Higher Education and Research, Belagavi. Welcome to you too, sir. My immediate left is Tejinder sir, or TS as we popularly refer to sir as. Sir is currently the advisor of medical education here at the Guru Ramdas Institute of Medical Sciences. He is a pediatrician by training, and sir has been instrumental in establishing the Famer Institute in Ludhiana. Welcome to you too, sir. Joining us online is Professor Jamkar. Dr. Arun Jamkar is the former Vice Chancellor of Maharashtra University of Health Sciences. He is currently the consultant healthcare for Persistent Systems Limited, Pune. I think we'll also have Dr. Payal who will be joining us and introduce Dr. Payal once she joins. So I think that's the panel that we have for you. Back to you, Dr. Chetna.
Thank you, Dr. Anand. We begin our discussion. Dr. Supe sir, we would like to know how do we really compare the objective and subjective assessment, and what are some of the pitfalls that you envisage in the objective assessment?
Fine. I think as many years, when we started learning, actually, we started predominantly subjective assessment. And then over a period of last, say, 4 decades, we have seen the objective assessments coming in a big way. And probably it's an objective pursuit which has taken over last 2 or 3 decades or 4 decades in our country. Now, what is in the objective assessment? I'm sure we know everybody that it's the phenomena of checklist, ticking boxes, scores, and structured kind of an assessment where you and you feel happy that I have done it and you get that satisfaction and knowledge. And these are mainly pushed by the courts in our country, especially for selection. And for skills, it is definitely OSCE and DOPS and these kind of things. And for attitude also, there are many rater scales. When you talk about subjectivity, especially, it is judgments. It's basically impressions, your gut feelings, and what are you really looking at overall kind of an assessment of a student. And it is like you normally would like to do, he has done above the expectation, he has done below the expectation, or he has done as per expectation. These become sometimes the kind of the subjective assessments. Now, if you really see, in 1960 was a pursuit when the objectivity started creeping into education. But this was what we call as a pre-psychometric era. And then came the psychometric era, where people started looking at the numbers, analysis, and your growth and all. Now, if you really look, there are a lot of myths of objectivity also have come. Now, when you look at the low level of knowledge and some part of the skills, I think there the objective assessment is fairly okay. Like say when you have single question, single choice-based MCQs, or when you have say OSCE that you have picked it, this is done or this is not good. But as you start growing from the higher level, from the lower level of cognition to higher level of cognition, or when you start going towards the different levels of attitudes and skills and the expert judgment, then you suddenly find that the objectivity has its own limitations and there are some pitfalls which are seen. To give a simple example, if somebody is making a diagnosis, something like say neurological diagnosis, if there are 2-3 experts decide that, okay, this is what diagnosis, and that is on the basis of which USMLE or many other exams are decided, whether the student has done right or wrong. Now, this is where a lot of subjectivity comes into picture, even if it's an objective assessment, even if you're giving marks, that is one aspect. Secondly, you will always find that as we go and we make a choice, like rater says, this is good or this is bad. When you do Likert scale or when you do rater's assessment and you start putting an expert and he starts sticking and giving numbers, you always find that if one person says this, other person may not completely agree and the numbers may not be same. So there's a lot of context which comes. To give you another example is like, if somebody is doing, say, BP checking, and somebody is making a diagnosis of hypertension or a little complex diagnosis. Now, up to, if you have he follow all steps, it is okay. But when the judgment comes about, what are you really going to do? At higher level of which objectivity really fails to some degree. But I think this is one aspect all of us should remember, that objectivity is not fully objective. When it comes to higher levels of thing, there's some amount of subjective bias that comes, and it's like then experts define standard settings in their own mind, especially in the complex situations which a clinician faces. Or when the complex problems are faced in our medical situation, the experts have their own standards. And that is where I feel the expert judgment comes in, even if you call it as an objective. And I feel that context specificity we need to do, and what we call it as a noise into the signals of objectivity. This is what is a term which is used in literature. So I think everybody should realize that yes, we call it as an objective assessment, but it is not truly objective at a higher levels of cognition and some parts of the skills. So I think this is one where we should be very clear in it.
Thank you, sir.
Yeah, let me just quickly introduce Dr. Payal. Dr. Payal is Professor of Surgery and Medical Education, Maharashtra University of Health Sciences, and is currently with DY Patil College, Pune. Over to you, Chetan.
Thank you, Anna. Hello, Dr. Payal, how are you?
Yeah, hello, Dr. Chetna. I'm so sorry for the slight delay in joining.
Oh, absolutely, all right. We are so happy to have you here. Payal, we'll just begin the discussion. And we have a question for you. Why have objective assessments been given such a prominence in so many years now? And why has subjective assessment been undervalued? What do you think?
All right. So I listened in to Dr. Supe sir's elaboration of objectivity and what it means in our current system and the various facets and dimensions related to assessment. So just a minute to dwell on the term objectivity. So the term objectivity refers to it comes from the field of measurement science, and when we say measurement, we are trying to give a number to something, whether it's a physical object, so whether it's how tall a person is. You're giving height. How much does a person weigh? So to physical objects, we're trying to give a kind of a measurement attribute in the form of some number. Same way for some mental, first time it came into mental attributes, the science of measurement was with measurement of IQ. Then later, as the science of psychometrics, it came to be known as, progressed, we started using this science of measurement in the field of education also, which is very unlike what we used to have, earlier in our gurukuls, you could say. And the same apprenticeship model was there in the West also, where the person under whom the student is undergoing the training would decide, at a certain point of time regarding the level of competence and whether they were fit to perform that particular, task or role at a certain point of time. So the judgment was a human judgment made by a guru or the person, the expert under whom the apprentice is undergoing the training. So with the advent of this objective and measurement, methodology, the role of objective measurements came into education when we found that there were flaws in the way human judgment was being made. When we were conducting exams, when education became available to more people, when we institutionalized it, when we started carrying it out, in the form of colleges and big universities, when number of students increased. Now, in the last 20th century, the knowledge volume has increased a lot. So that has brought about this measurement science and therefore made it easier for us to use it. So that is one aspect. Second was that there were errors. So errors in human judgment. The aim of measurement is to make any, the measurement free from error. So the tools that we develop for it, we keep on researching them and improving them till they become error free. So earlier we used to have like a stone for measuring weight, but now we have such sophisticated calibrated instruments. So that tool was found to be better than human judgment in education and health professions education, because there were certain errors which were recognized in, in making the decision about students, whether they deserve to pass or fail, etc. And what were those errors? There were various kinds of biases, as sir has mentioned. So the biases could be, personal biases, whether I like somebody or not. They could be those conscious bias. A subconscious bias could be, racial, gender, or I just don't like the look of the person. So some unconscious biases could be there. And the third one was cognitive biases. Like we all have heard of the hawk and dove effect, the halo effect, so those effects resulted in, some examiners being too strict, some being too lenient. So inter-rater variability was seen. And these were not fulfilling the criteria of validity and reliability, which had been laid down as a part of this progress only. So the field of objective measurement was seen to be, promising in solving these issues, which arose, in the human judgment of performance of students. So that is how the objectivity became more and more popular, and we became more dependent on it. So I hope that answers the question. And so the reason for subjective assessment being undervalued were these errors, which were being seen as creating bias and being unfair to the students.
So we'll come back to that again, Payal.
So I think what the panelists have brought out beautifully so far is what is the importance of objectivity, how objectivity came into the forefront and how subjectivity got pushed back. So now let's try and understand. I will direct this question to Tejinder sir. So what is the role of expert subjective judgment, especially in the context of the current CBME, more so in terms of performance assessment?
Thank you, Anand. In fact, before I start answering your question, I'd like to elaborate on some of the points which Avinash and Payal have made. Now, we say objective is something which is not influenced or likely to be influenced by the personal bias, choices, etc. Let's take MC, the ultimate example of objectivity. But even MCQs go through a lot of subjective intervention. When you decide on a blueprint, it's subjective. When you decide which topic to be included in the assessment, it's subjective. What question, it is subjective. What should be the distractors, it is subjective. What should be the language of the STEM, it is subjective. Standard setting, it is subjective. So it's not that even MCQs are highly objective. And when we come to OSCE checklist, for example, you can draw a very elaborate checklist. But if I am the examiner and I want to say favor some particular student, nothing prevents me from putting a tick or not putting a tick, irrespective of what the student does or what the student doesn't. So Vander Luton and Jeff Norman, the two leading experts in assessment, in fact, gave it a very nice name, and that is objectification. Objectification is that when you make decisions subjectively, but try to measure them objectively. So actually what we are doing in most of the examinations is that we make subjective decisions. If that was not so, then all the entrance examinations, now of course we don't have many, but when there were multiple entrance examinations, then all of them should have had similar questions. All of them should have had the same student getting the same ranking everywhere, but that didn't happen. So obviously objectivity was probably over rated. And what we were doing is objectification, and objectification does not necessarily give better results. Now come to another example, multi-source feedback. Now in multi-source feedback, you are getting the opinion of so many people around the trainee, which may be colleagues, which may be nursing staff, which may be ward helpers, which may be patients, and so on. Now everybody will give a different opinion. Not everybody will have the same. Now, that is not a weakness of multi-source feedback. In fact, that is a strength of multi-source feedback, that it allows you to have a complete 360-degree picture of the student's abilities, competence, behavior, performance, and so on. Many CX, for example, there will be so much wide variation in the ratings because they are quote and unquote subjective. But then that is the strength of subjective assessments. Right. Did I miss anything?
No, I think you have built the case as to why expert subjective judgment would have a role. I mean, it's not just sufficient run behind those objectivity. We have understood this objectification is different from objectivity, and how in a pursuit of objectification, the concept of objectivity still has, as even Supesa said, a lot of subjective components gets included in it.
Yeah, and just to make sure that anybody listening to this discussion doesn't get a wrong idea. We're not saying that you discard MCQs and start using essay type questions and so on. As Avinash rightly pointed out, if you actually look at the Miller's pyramid, the lower two levels are fairly well settled. You know, we have good assessment methods, we have a lot of psychometrics, we have a lot of ways to make sure that we get good results. But when you move on to the higher two levels, that is where the problem actually starts. Because you cannot objectively assess a number of competencies which are extremely important for a doctor, but which get missed out simply because they are not objectively assessed. True. Look at the roles of Indian medical graduate. Now we have given 5 roles: clinician, professional, leader, lifelong learner, and communicator. Out of these, clinician is probably the only role which can be objectively assessed, although even that is not fully possible, because even to be a good clinician, you need to be a good communicator, you need to have good professionalism and so on. So that means out of 5 roles, we have left out 4.5 roles from assessment because they cannot be objectively assessed. Now, what will happen if you leave out, for example, leadership? Now, after a certain period of time, students will also realize they are not assessing this, so why bother about it? They are not assessing communication, why bother about it? So ultimately, we'll still be left with only half the role, that is clinician. So that is my plea, that we need to expand the area of assessment for the students.
Point very well taken, sir. I think going back to Dr. Payal, I think sir touched upon the 4.5 roles which are not assessed even by the objective methods that we use in our current assessment system. So earlier we discussed about as to why subjective assessment went into the background. So if I may follow it up, what do you think are the potential barriers towards expert subjective judgment being used, and how do you suggest we overcome some of these barriers? Dr. Payal, you are muted.
Yeah, hello. Yeah, sorry. So thank you for the question. So yes, further taking it up, once a mindset is made, it is very difficult to change it, So I think that is the biggest barrier, that the fact that, the objectivity is removing bias, it is removing the unfairness due to, personal and interpersonal factors. So when we bring back subjectivity, those factors are going to come in. So how are we going to factor for those? So that is, I think, one of the biggest barriers in the mind of people who are preferring to or not giving up objective assessments, whereas or willing to do that. Objective assessments at the lower level of the Bloom's taxonomy, as Supe sir has mentioned, and as Dr. T. Singh sir has reiterated, it does have its own value, whereas we kind of use it to ensure that everybody knows at least the minimum things that they're supposed to know. So that use is there. And as sir said, we are not writing off these methods. So it is important that we have to use a blended approach. So I think the first thing is to tell people who love objectivity is that we are not writing it off. So changing the attitude is most important. And then there's a lot of work, further to that. And it would mean, first of all, our understanding of these things. In today's situation, we are in a position to have a much better understanding, because we have access now to a much wider domain of literature, and we don't have to just borrow from the West and use tools and things. We can create our own, we can analyze what they have done, we can learn from their failures and their successes. So that is one thing. Secondly, our own context should be the driving force, when we learn to design our assessments. So I think that is something very important for all of us, teachers and faculty, to learn how to design assessments, going through all these literature and trying to make our own understanding clear about all these things. Further to that, I think once we have that understanding, it is valuable to use all the tools for their strengths. So whatever, like if, MCQs give you much wider sampling, then why not make the best possible MCQs? With how can we balance them with, other supply methods of assessment, like the SAQs, LAQs, etc. So that deliberation needs to be done in depth, and the blueprint for, all our assessments need to be created in an informed manner. So that will remove or balance a lot of the subjectivity, or not subjective, the bias element of subjectivity, I should say. So doing like evidence-based decision making, evidence-based use of assessment methodologies is the way to go as well. Also, by increasing, so making stronger blueprints with all these aspects, then having more people evaluating, because the human judgment, human element, so that gets eliminated with increasing the number of raters, or the persons who are evaluating or assessing a particular student. Then other way to do is giving the student an opportunity in multiple situations. So for the same task as well as for different tasks, to increase the sampling and understand the depth of attainment of the required competencies. Finally, the approach to, how do we, this is all very nice to say, but how do we achieve it? I think it can be achieved, it needs to be achieved both by a top-down as well as a bottoms-up approach. So at the bottoms-up, we have already introduced, through the CBME curriculum, the programmatic assessment, and everybody is being, and faculty development, everybody is being encouraged to use these tools at their formative assessment level. So as and as we get better with this, so we will be able to bring it to the include the assessments which are happening at the formative level to inform the decisions about the student which are being made at the summative level also. So that it's a slow process, but it will happen, and the support has to be there from top down as well.
I think as you rightly said, it's a slow process, but I think it's something that will eventually happen and will surely happen.
Yeah, absolutely.
And taking Dr. Payal's discussion further, Dr. Sauji, we would like to, could you elaborate on how can we, one of the basic perception regarding this subjective assessment is the lack of fairness, perceived lack of fairness. We don't really say that there may be a lack of fairness. So how can we overcome this barrier, and how can we make subjective assessment more rigorous? Can you tell us?
Yeah, actually, that's again a very important question, and I think Dr. Tejinder and Payal has alluded to it. What I would like to maybe say 2 or 3 quick points
is number one, then we need to understand as to what is the purpose of the assessment. So obviously, I mean, where it's a low stake assessment or a high stake assessment, which is there. So once we know that some element of bias or some element of the decision-making process is there depending on the stake. So high stakes examination where they have to be really defensible and they have to be rigorous. So obviously there is no chance of error, or there has to be a minimum chance of bias in that assessment. So number one is we need to define the purpose, why, what is the assessment and why it is at what level. Is it for certification or is it for assessment for learning? Or purpose of right? Yeah. So that's number one point. Then, of course, as Payal has said, that to minimize the bias or to bring in the fairness, being in the same context. So obviously, I mean, we have to use multiple tools which are there. Multiple raters have to be there. And then as in the morning also, I think Dr. Matthias, and I think all these, I think probably this session is synthesis of all what has been said all throughout the conference. Right? So I think all of them have said that, okay, I think how do we minimize the bias? So expertise of the raters or the experience of the raters or the examiners which are there. So more they're experienced, obviously, quote unquote, they may be, I mean, minimal of the bias. And the bottom line to all this thing, I would say, is a faculty development. So, I mean, if we have a really strong faculty development initiatives which are there, then obviously we'll be able to address these concerns which are there. And I mean, just give me a minute more, because faculty development these days, I mean, we're doing 1-day workshop, 3-day workshop, basic course, SCME, etc. But we really are not having the real impact of these workshops. I mean, fine, we'll say that, okay, they're still addressing the lower level of Patrick's evaluation, that awareness is being spread and so on. But how long awareness? We really need to have some action now. And for that, then I think we need to have a continuous or a longitudinal faculty development programs. As I was talking to, I mean, Dr. Rashmi in this previous session on motivation, how do we sustain the faculty motivation?
Right. And sir, and in this case, there's one more barrier being perceived, that especially our Indian medical schools, the class sizes are very big, and subjective assessment is considered to be more, more human resource intensive. So how do you think as we could overcome these barriers, sir?
Yeah, again, I mean, this session was asked in the morning. I think Dr. Matthias session and Dr. Karma and that panel, the same question probably was asked. Right, in the WPBA. Yeah. So in the little larger context to that. So obviously we have to have a bigger pool of examiners or assessors or raters. And then as they rightly said, peer assessment, it's there. I mean, residents, I mean, why we should not be using the expertise of the residents which are available with us, and then the other colleagues in the departments which are there. And then somewhere we can also use the technology. So I mean, there are now lots of tools which are available. So somebody is maybe performing a procedure. A video can be recorded and it can be viewed later. It can be a self reflection on that, as well as the expert can review it at a later point of time. So, and apart from multiple ratings, now technology, it is available and it can very well be
maybe
used.
With the NMC, we could back for a better student-teacher ratio.
No, of course that's there, but that's asking for something which is not in our hand. I mean, we can ask that, but I mean, I don't know politically, and there may be so very many factors which influence that. But what is in our hand?
Right, sir.
Can I just add here one thing? At the undergraduate level, the expert subject judgment has a limited role, but it has a role. Especially the way students analyze, take decisions at a higher level. I think this is where the experts are, and it may be in a formative and feedback role. It may not be in a really final examination. You may also, there's automatically when you have a long case and a short case, there is a little point, but it may have more role into the formative and the learning kind of feedback, and has some limited role into a higher clinical decisions. I'm sure it has a role.
Right, sir. So I think I'll go to Professor Jamkar now. Sir, if I may just again take a cue from what Vivek sir said just now, one of the things is faculty development. So do you feel our faculty are ready for expert subjective judgment? What do you think could be done so that faculty are more receptive to this idea?
Thank you, Anand. My network was gone because of electricity failure. Therefore, I was not able to follow our complete discussion. So excuse me for maybe some repetition of whatever earlier learned faculty has talked of. The question is very nice. I just wanted to put in what, so what, and now what pattern. So your question is whether faculty is ready for it, and if they are not ready, how to make them ready. Obviously, they are not ready because at present they are working with all CBME, and then there is a lot of stress and strain because the second year has just started, and therefore clinical things are going on, vertical integration, horizontal integration, that whole thing is going on. So at that matter, they may not be entirely ready to accept some changes, but we need to convince them first that all this discussion is going on about assessment of CBME, and therefore all these CBME assessment has to be thought of parallelly, not and simultaneously. I think that is the first point of conviction. And the other thing is we are not discussing about all these methods, subjective assessment for cognitive domain. We are discussing about performance. And the best part of the story is all these faculty are trained. The NMC and Medical Council of India, they have taken enough efforts to have CISP. But then we need to sensitize them about the whole life history of a medical education development, especially in case of assessment. We have traveled from totally subjective assessment where performance appraisal was done by a long case, short case, and spot. And in PG exams, the weightage was given and the mistakes were highlighted. And then where you remember A, B, and C. If you make a blunder, you are in C. And that actually that is one of the best things to happen because you make some blunder, you can't become postgraduate. And unless you are B plus or A, it is not nullified. So people fail. And sometimes that failure was so subjective. I remember one of my colleagues appearing for MD Gynac, and she was given a case of a twin. And then she said it's not a twin. And subsequently, there was no twin. But then the lady failed. So this is completely subjective. So because of these assessments were guided by attitudes, values, orientation, and prior experience. That's why systems say subjected to objective assessments, grades of marks to we have seen whatever were enduring. Objectivity without interference of personal opinions, preferences, modes of observation, views, interest, and everything. And therefore, this whole thing is trying to reflect what is called the noise of objectivity. But when these assessments were implemented, these desired quality of learner, we realized that a true score exists. With any existing assessment tool, the derived score will deviate from this true score, what's called a measurement error. And however, in medicine, we are not concerned about marks. We are concerned about solving problems. Therefore, objectivity of a true score standards can be questioned. In addition, our choices are multiple. There might be multiple answers available for same case. And I think making them objective would be unfair. So medicine often requires multiple answers, options suitable for given clinical condition. Therefore, subjectivity becomes more important. So I understand objectivity is defined as preluding the personal biases of SSC. It could be argued that even a large-scale MCQ test are not objective. Indeed, very test question created by individual, often an expert, represents a value judgment regarding what materials were testing and sometimes even best answer.
As you rightly said, our panelists touched upon this aspect that even the MCQ, the so-called objective test or the OSCE,
they are not objective. I think today's panel discussion can sensitize them and brief about the potential drawbacks of objectivity, and whatever subjectivity we need to introduce has to be an expert subjectivity.
Absolutely right.
Now, I understand we hardly have expert in medical education in 90% of the colleges. Let us be honest. Whatever are just full-time, the full-timer strain is disappearing. And I think all these attempts need to sensitize, need to explore them, extrapolate them so that they would be ready. And therefore, these panel discussions would at least sensitize that tomorrow, if you want to make CBME successful, we need to have an expert subjective assessment.
Right, sir. So that is the aim of this panel discussion, sir, to sensitize rather than find all definitive solutions today itself, sir. Sir, but drawing from your experiences with the universities, could you opine on what could be the roles of universities in implementing subjective assessment in the institutions?
Thank you, Chetna. I think universities will have a bigger role to play in all of these developments. At the end, what you called as the pleasure of cake is in eating. So at the end, you want universities to implement, and therefore you need to understand the whole anatomy of an institute. You have what is called as the board of studies, faculty, academic council, and everything has to pass through this what is called as life history. In addition, this being an assessment, it has to go to a BOE. So the first thing we need to understand is how to enter in this whole system. So let us say we decide to prioritize that this expert subject assessment will be only for postgraduates. So we'll have only 2 board of studies, maybe medicine, medical sciences, and surgical sciences. So it can go either from the top or from the bottom or simultaneously. So let us say we convince VC, and then he can appoint a committee of academic council to go into these patterns. The chairman board of studies can appoint, or even a chairman BOE can appoint. The whole thing, this has to be done in a systematic manner. So if you realize the best guy is a vice chancellor. So this is one chart. At the same time, you need to prepare faculty. So I think the parallel event has to be started. In FDP, at least in the clinical and paraclinical, we need to create a curriculum for FDP. And obviously, we require a hybrid model where everything is exposed to online methods. The third thing, what we wanted to put is research, because at present, all the subject assessment, whatever expert, is reasonably fluid. So we need to develop into assessment tools to find out which are working. So maybe another job for all medical education units, especially in the reputed colleges, to go into finding out what are the various tools available. And the best way is to go simultaneously across. And one of the pattern which I wanted to find out is we have an association of medical universities of India, where I was a founder president. So we could start simultaneously at least in 12, 15 colleges. So coming back, we need to convince vice chancellor, and vice chancellor will be only convinced where we talk what we call as pragmatic. So I will quote Vanderbilt's talk that we have 5 criteria about any assessment: reliability, the degree to which the given instrument is accurate, validity, everything is discussed about. The third thing is impact. Fourth is acceptability of a learner and faculty. The last one is cost, because that cost nobody considers. And if you see the basic question of reliability, Tejinder is there, he has been talking a long time, that the longer the time of sampling, longer the time of evaluation, the reliability improves. And therefore if you see,
the point is very well taken. I think you've given us the roadmap of what we need to bring as to how universities could be in the forefront, how faculty development.
No, this is most important, because suppose you want to follow an USMLE pattern where they spend 41 hours. We have to evaluate 50,000 students in each term and maybe 30,000 postgraduates. And therefore, if you take so much of time, you require 1 5-year plan.
Absolutely right. If you dwell again on too much time on this, I think we'll run out of time for this panel discussion. So my sincere apologies. I need to now Tejinder sir with the burning question. I think, in fact, Supe sir touched upon that in terms of where we could use expert subjective judgment. Sir, if I may go into more specifics, what are the competencies that you think are most suited for expert subjective judgment?
Before I answer your question, I would just take you back to what you do to a patient. Ultimately, what is assessment? Assessment is a diagnosis of the student's abilities and further need for improvement and learning. So let's compare it with what we do with a patient and vis-a-vis what we will do with the student. When a patient comes to me, I take a history, which is the narrative part. Then I do the physical examination, which is the subjective part. And then I send him for investigations, which is the
objective part of it. Now, no clinician or no medical teacher will teach the students to replace history and physical with more and more and more tests. Because that will not solve the purpose. You need all three components. So if we look back at what you asked, what kind of competency, then look at the IMG roles. Professionalism needs subjective assessment. Communication needs subjective assessment. Leadership needs subjective assessment. A lifelong learner, subjective assessment. And many of the competencies, even in the clinician role, also need lifelong assessment. See, in addition to what Avinash and Vivek had said already about faculty development and faculty training, I would add little more to it, that a lot more buy-in is required. And that buy-in is from the students, from the society. Ultimately, they are the ones who might be having this feeling they do not trust us. So they may be not willing to accept our subjective. And subjective assessment doesn't happen in a very short term. It's not that from tomorrow onwards we'll start having subjective judgment. Subjective judgment happens over a long period of time in an atmosphere of mutual trust. And unless that happens, subjective judgment is not really like to succeed. Just look at what happens in a court of law. The magistrate doesn't sit with a checklist. He only listens to the arguments on both sides, and based on those arguments, he forms an opinion. Now, I find how strange it is that on the subjective opinion of a judge, we can hang a person. But to tell a student, beta, you need little more preparation, we need objective. That is the crux of it.
I think you're brilliant sharing. So I think.
Usually we say there might be argument about whether the sun is shining or sun is not shining, and there might be clouds around, but judge will give judgment sun is shining. This happens often. I think that the expert subjective judge has its own limitations.
Yeah. Sir, can I say something here at this point?
1 minute. Huh?
Okay. Yes. Sure.
Now, coming back to this same hanging sentence example. Now, it is not that the judge passes the judgment and next day they hang the person. It has to be confirmed by High Court. Right. And then there is an appeal, and then there is another appeal and another. So something similar we need to build in our system. If a student is not satisfied with your judgment, today morning we heard about the role of competence committees. Right. These are the ones. We have curriculum committees, we have medical education unit. So let there be a provision for appeal, where a student can actually appeal against if he or she is not satisfied. So that
the university will have to conduct another set of examination again.
If we look at the purpose, sir, I'm not suggesting that you do away with the university examinations or you do away with the selection examination, but a whole lot of formative and internal assessment, and more so now that internal assessment is not going to count towards the final result. It's high time that we bring in more subjective assessments into those areas.
Agree.
While you had a comment, a quick comment from your side.
Yes, two things. One, I agree with Dr. Tejinder sir that we have to. I think there seems to be a possibility that this can be done at the institutional level, because now the marks are not going to count towards the final exam. The important thing here is that finally students will study for PG entrance or something. So without much delay, we should be looking at aligning our formative assessment system with the the final assessment, or what the students are going to be tested for in the summative exam. So that alignment should begin top down also, I think, along with faculty development. So that's I would say an intervention or an action which should happen soon, as subsequent to this whole discussion that we are having. Secondly, the point which Dr. Jamkar sir raised about the skepticism with regard to subjective ability of the experts. So I think strengthening the criteria for being an expert, or defining the criteria for being an expert. Many times it doesn't sound nice, but say, oh, usko to kuch bhi nahi aata. students will say that about a teacher. So we haven't yet set our benchmarks for experts. So like our CME programs are not well, established, which is the case in many other countries. So, so the definition of an expert, both in their own subject, both for the level of the learner, which could be UG or PG, and for the field of education, because they are the ones, the senior ones are the ones who become examiners, who become paper setters, etc. So the definition of expert needs to be, thought of and strengthened.
Thank you for bringing out the important point of alignment and ensuring as to who is an expert. Because I think what we're saying, we're not speaking about just subjective assessment, we're speaking about an expert subjective judgment. We are not speaking about going back to the old days when the candidate was, if I may say, the mercy of the examiner. If the examiner liked the person, he would pass that person or then he would fail. We are not looking at that at all. So what we are speaking specifically is about expert subjective judgment. And obviously, in this panel discussion, we have touched upon some of the things that we need to be careful about. But if I may put this sort of the last question to Supe sir.
Anand, I just wanted to add one thing. Ground reality today, as a university, 90% of medical colleges have 100% result in postgraduate exam. Is it subjective? Still, it is objective. And still everybody passes, because I hope you remember when we were appearing. And suddenly everybody has become so intelligent that everybody passes 100%.
Okay. So I think the point is taken. The point is well taken. So let me go back to Supe sir. Is what so I think there has to be certain safeguard. We need to have certain sort of do's and don'ts. If I may ask you, so what according to you would be the do's and don'ts that we need to be adhering to when it comes to expert subjective judgment?
I think I'll give you a simple example. The first thing I would like to say that don't discard subjectivity completely. I think the expert subjective judgment has its own place. Only thing we have to use it at the right place. And I'm sure we are on honking on the objectivity, but subjectivity has its own place. To give an example, simple example. See, I am a surgeon. I have a resident. I do a major operation and I allow them, say, particular resident that now you can close on your own. Now, at this particular stage, I do not evaluate him objectively. I don't say how many abdomens he has closed. I probably have subjectively assessed him that he has an ability to close the abdomen on his own safely without causing any complications and putting all those stitches and all that one. Now, when it comes to a complex or whenever there are clinical situations, I think in a routine kind of an educational processes, I think expert subjective assessments have their own place and we should continue there. We should not really discard it. The only advice I would give you is that have multiple kind of times use this, create a pool of multiple subjective assessment to remove bias. I'm sure the faculty training, what you've said, everybody said is okay, but faculty training in these levels is very difficult, especially the PG teachers and all that becomes very difficult. But at least we can do it multiple times. Shared responsibility and shared decision making and having a system where people can really go above, like Tejinder rightly said. If somebody does not like subjective assessment, there should be a mechanism, an open atmosphere. Now, these are something which we can do. Don'ts, I would say currently we are not ready to change subjective decision making for assessment for the high stake exams. Currently, we have to use probably the blended approach, especially, and then over a period of time, when we see little better change over a decade, maybe we can add a component of subjective assessment in our country. Maybe many countries they use subjective assessment. We probably need to be more work on this before we bring it into the practice.
I'll just add one word in do's, and I've been saying it all throughout, and that's probably one word. Yesterday also I mentioned that, and it's about strengthening the feedback system.
Yeah.
I think that's something which we really, as the learner, whether he's learning or if he's learning good or what are the opportunities for improvement. And so if we really want to make this subjective expert, so we as a teacher should be trained to give feedback and the students should be able to seek and receive feedback and also reciprocate about it. So if you're able to maybe bring in this competency of feedback in our whole of the system, I think we'll be able to improve a system in a great way.
Right, so thank you. So
Anand, I just wanted to put one more point.
So we could, we now invite one question from the audience for want of time.
No,
Yes.
till then, just I wanted to put one idea which I think everybody is forgetting. It's
Yes,
about
sir.
acceptance of the faculty.
Yes,
In MUHS, we already started OSCE in ophthalmology post-graduation, and there was no FDP or nothing, and examiners converted it into a spots. So I think the acceptance by the faculty for any development is very, very mandatory.
Right, sir. Thank you. I think, sir, Dr. Anshu has a question for us.
She also wanted to say something.
Yes, sure. We can take.
I've been listening to all of you very keenly, and the more I think about it, I'm convinced that the only way of making all this acceptable is to reduce the stakes on examinations. I mean, if I think of any medical student, they start off in the 9th and 10th, the adrenaline levels are high, they're competing. The competition does not stop throughout the medical course, and it takes away the fun of learning. The moment you reduce the stakes, there is no question of whether any teacher is going to manipulate anything. What do we want? Do we want students to be first, second, third, or do you want all of them to be competent? And if you reduce the stakes considerably, I think as long as everybody gets equally competent, I think the work is done. The more you put your stakes into that cutthroat competition, the more difficult we are making things for everybody. I don't know, I would like your opinion on this. And how do we do this?
Very true. I think even I asked this question to Rashmi and she answered the same thing. You have to change the structure of your country. Now this becomes a very big task. You know, the basic problem was 17 lakh students are appearing for, say, good seats, which are only about 20,000. Now that's the disparity in our place. So therefore, everybody concentrates on that objective-based select exam, and they do not really give importance to these exams. Now we need to, as the seats will increase, maybe I personally feel probably the structure has to be changed where we have to have a mix of both these things together. As you rightly said, take away the load from that select exam. In fact, when Vision 2015 was really discussed, we had put this, that include each year's marks for giving admission.
Having a portfolio with all the feedback.
And give marks into that, add some component to that, 15-20%, and then add the select exam. Don't put everything on select exam. Now, models like this probably will help students. And for that, we need to bring little more standardization. There are a lot of non-acceptance of these by the universities.
Yes, I think can I say something here to add to the discussion?
It is not only the selection examination which causes stress. In fact, even day-to-day examinations in our colleges are also causing a lot of stress. Now, look at second prop. The day they have pharmacology or pathology examination, most of them will miss their medicine and pediatrics. So it is not just the final selection. It's, every day examination is a stress for them. And that can be undone only by spreading the examinations throughout the year, not really making each exam as pass-fail decision point, and using it as an opportunity for the student to learn in a better.
And in addition, with objective MCQ type entrance exams, nobody is attending clinic, nobody is attending lectures. It is one of the biggest casualty. We need to even introspect that idea.
Ladies and gentlemen, I think we can have discussions for hours today. I think the adrenaline, the enthusiasm of all the participants and the panelists on this topic, I think is very, very high. But I had to look at the objective measure of time. So unfortunately, since you exceeded the time, please allow me to please use the objective measure. And I think the chairperson is saying that we need to take one more question. So I think we'll go by what this. And I think Dr. Richard would be the last question, and we'll have to close this panel discussion. My sincere apologies to all of you.
Definitely the last one.
So when we talk about CBME, we've been talking about that the onus is on the students, to pass the exam. But I think a lot of onus is also on the teacher, because the way the teaching learning methods have been designed and the assessment has been designed, a lot of time has to be dedicated by the teacher. And so in this context, I was talking about that there are certain certificable competencies which have to be assessed and signed in the logbook. So a lot of time investment has to go through it. So, sir, I just want to ask that the everyday activities that we do, for example, the teaching learning methods like SDL or ECE, what does the expert panel has in mind relating to the assessment of it? Because there are certain people saying that you assess once you're giving the SDL or ECE, you assess the students. Some people say that you can, just give an assignment or just put in the logbook. So what is the take of the expert panel?
See, the next phase of all this has to go into the little use of technology in making the burden of the teachers and students less. I think one of the whole concept is like your skill development. Now, the use of technology for learning analytics, and then you can really say that, okay, this student needs more feedback. This student has reached to that particular competence level. It also gets recorded by on itself. So the student's burden is less, teacher's burden is also less. And it's ultimately a shared responsibility. So we need to use this. And currently people would say in the beginning, we are spending a lot of paperwork and time and all. If you use technology and analytics, maybe we'll be able to reduce the burden and we'll be able to use our time better for achieving the competence and also create a lot of pool of assessments for which we'll be able to take a decision, which not necessarily has to be subject and object, it will be a mix of both.
Yeah, but
Avinash, I think I just want to add, taking the clue of Avinash, I had already delivered one webinar on technology-based assessments, where we put an idea of 360-degree real-time dynamic assessment, where the student is totally followed for what he reads, what patients he sees, and then he undergoes an evaluation at a given time. I think that model where technology is rampantly used has to be used.
Finally, if I can say, can I just speak? Dr. Chetna, one sentence.
One sentence only, Dr. Man, please. Only one.
It's like TV debates now.
Yeah,
Only one.
Yeah, so if we have to create the environment which Anshu has asked for, which I totally agree with, I think we just need to rethink our design.
Thank you.
It's the era of design-based thinking. Just rethink your design.
Just to conclude this panel discussion, I think for the last few decades, objectivity has been a mantra, if I may say. Everyone was in pursuit of objectivity. All designers were in pursuit of that. However, I think today there is an increasing sort of agreement that for the assessment of developmental processes and competencies, expert subjective judgment would definitely have a role to play. I think that's what I think we have discussed in this panel discussion. Just as a clinician would not lab diagnosis, I will not rely on a lab report to start treatment. I would rely still on my expert subjective judgment. So too would be how we should be going about assessing our students. In this entire workshop, we heard so much about programmatic assessment. We also heard in this panel discussion some of the sort of pitfalls that could be there and how we need to avoid them and how we could take expert subjective judgment to the next level. And let me conclude by quoting what Harrison Keller said in 1976. That's 45 years ago. The major development effort in competency-based education should not lie in the design of instructional materials, but in the design of appropriate performance assessments, unquote. Ladies and gentlemen, I think that is what we should be looking for. We should sort of reinvent, not relook into strategies that we have been using for assessment, and expert subjective judgment is something that you could all consider when it comes to framing your assessment design. Thank you. That's it from our side. A big thank you to our panelists, both to the online panelists and to the panelists who have been here. Thank you all.
Thank you. Thank you, one and all. It was a great pleasure. Thank you.
Thank you for a wonderful session. Now I request Dr. Sahiba Kukreja to please facilitate our panelists. Dr. Avinash Supri.
Avinash.
Dr. Avinash Supri.
Thank you. Thank you, Maharaja.
Dr. Jivesh Sawaji. Dr. Tejinder Singh sir. Our moderators, Dr. Chetna Desai.
Color combination, oh my God.
He tried his best.
He's been pre-warned by Siraj. That's what it is.
I'm sure we can all hear the discussion.
And how about visiting us online?
Dr. Jankar.
Yeah.
Now there is a Dr. Bill's lecture. Please attend that.
Of course, I attended everything from morning.
So moving on.
No, Dr. Jankar, I have accepted felicitations on your behalf.
So let's move on to the last lecture of the conference. Light the path forwards towards effective evaluation. So the theme of this conference is looking back to leap forward for curriculum innovations. And what better to look back at and evaluate the program in terms of outcomes. So let's listen to the role of evaluation in sustaining educational innovations in general and competency-based curriculum in particular. And we have a very well-renowned speaker with us to share his views. The chairpersons for the session are Dr. Avinash Supe and Dr. Anil Kapoor. May I request the chairpersons to come forward and kindly take their seat. So may I request the chairpersons to kindly introduce our speaker.
It's an honor and privilege for me to introduce my mentor, Dr. William Burdick. We call him as Bill. He's the Vice Secretary General of the Network towards University for Health, that is NCHPE, an organization of community-oriented health professional schools, as the former Vice President of Education of FEMA. I think he was the one who started the global faculty development programs for the health educational professionals. He has received awards for excellence in teaching. He has been part of the emergency medicine of the Drexel University. And I'm sure all of you have heard him before. So I invite Dr. Burdick for giving his talk. Can we start his talk?
Hello, my name is Bill Burdick, and I am Vice.
This is not shared. No, have you shared it to the everybody? Sure.
Secretary General of the Network Towards Unity for Health. And today we're going to talk about lighting the path forward through effective evaluation, or another way to put it is forward-looking evaluation of education programs. And I'm hoping that by the end of this session, you'll be able to apply basic education principles to evaluation tools, list models of evaluation and describe their main utility, align the model of evaluation that you choose with your evaluation goals, cite fundamental values and steps of something that's called developmental evaluation, and use the evaluation processes to keep education innovation processes moving forward. Now, I don't need to tell this audience that, but it's key to emphasize that the fundamentals of teaching will always apply. We need objectives that lead us to education methods, that lead us to assessment. And all of these three things need to be aligned. Our objectives need to be clear, and as Ron Harden likes to call them, SMART. So they need to be specific and measurable. And those are the two biggest challenges with any education objectives. But in addition, we need to ask ourselves, is our learning process goal-oriented? Those clear objectives are part of that. And if we're using the concept of competencies, which are complex sets of behaviors, skills, and attitudes, there need to be objectives derived from those competencies. Is the learning process cumulative? Does it build on prior knowledge? Are misconceptions corrected? Is the learning process contextual? Do we tell our learners what setting or situation the information is to be used in? And is the learning process active? And for a large body of evidence on this subject, I suggest the Michael article, Where's the Evidence That Active Learning Works? Does the assessment program have the key components of a solid assessment? Is it valid? The inference, that is it valid? Is the measurement instrument stable? If we give the test on 2 different days or places, are the exams equivalent? Does it have an educational effect of improving learning on our students? Is there an opportunity to feedback, which is often related to that educational effect? And is it feasible? And for a really nice summary of what we know about assessment, I suggest this book called Knowing What Students Know. So the important elements of education are design, a clear education program with clear aligned objectives, methods, assessment. Feedback to learners is clearly paramount. The curriculum needs to be relevant to the needs of society. The faculty needs to be prepared and enthusiastic. The environment needs to be comfortable with just the right amount of tension so that there's learning, but no one is feeling paranoid. Students need to be appreciated as individuals, and the interaction between and with students needs to be emphasized. So it leads us to this question of whether these efforts are effective. Are we teaching students what society needs them to know? Are our students able to apply knowledge? Can they communicate effectively? Do they understand the social factors that are needed for wellness and good health? If we have innovations, how well are they working? And by what measures are they being assessed? Are we teaching our students in a way that will prepare them for the future? Are we teaching them what they will need to know? Examples might include telemedicine, remote consultation, data collection, management, geomapping, artificial intelligence, and many more. So are we giving them the skills to be self-directed learners? These questions often fall under the rubric of program evaluation, which is the process of systematically collecting data, analyzing that data, and using it to review the effectiveness and efficiency of programs. And I've highlighted the word review because that's a looking backwards kind of word. And in a moment, I'll talk to you about looking forward in evaluation. But that's the traditional definition of a program evaluation. And it helps us answer the question, how do we know if we're meeting the needs of society? Because that really is the raison d'etre for our educational efforts. We want smart students. We want students that are satisfied. But at the end of the day, we are in a position to support the needs of society, and we need to answer to our constituents whether we are meeting those needs. There are many, many models of evaluation. And again, I think this group is probably quite familiar with them, but they each have a somewhat different orientation. The SIP process created by Stufflebeam in the 60s is process oriented and talks about the context, input, process, and product. Kirkpatrick model, which is intended for educational programs, is results oriented. Did the learners like it? Did they learn? Did they apply what they learned? And what's the social impact of that learning? I've included Kern, which is really a curriculum development process, but that goes through all of the context and the input things that SIP addresses and includes evaluation. And then there's patent. And patent is known for purpose-oriented evaluation. What will the evaluation be used for? And it is patent that has developed the type of evaluation that I'm going to focus on. And this is the SIP model, which I think, again, you're familiar with. There's context, which talks about the needs and the problems, the environment. There's the plan, which is this, the strategy and how much money do you have to spend. There are the actions to implement this program and monitor its effectiveness, and then to understand the outcomes, impact, effectiveness, and sustainability. The piece that's missing in many of these, if not most of them, is this notion of understanding the relationship between our desired outcomes. And this is sometimes called the outcomes chain, the program theory, theory of change. And it addresses the relationships between outcomes. So if an outcome successfully occurs, then what other outcome may be achieved? For an outcome to be successful, what outcome must come first? It implies cause and effect. It helps to identify intermediate outcomes, or I sometimes call them intermediate metabolites, which may be more causally related to your intervention because they're simply closer temporally. And it is essentially a series of hypotheses. And it might look something like this, where you've got an intervention that leads to a certain outcome that then, if that's successful, leads to another outcome and another and another. And it's not necessarily exclusively linear. There may be some loops in there that feed back to other outcomes. Now, most of these models identify the purpose of their evaluation. They start with the context or need. And as you know, if you don't know where you're going, you won't know when you've gotten there. They try to understand the process in many cases, not all. And they're looking for the effects on people, whether those are the learners or whether that's the community. And measuring people, their knowledge, perceptions, behaviors is a complex endeavor. And it involves relationships, and it's dynamic, it's changing. Recognize that these models are not mutually exclusive. And what I'm going to advocate for is a blending of these models, picking and choosing the aspects of these evaluation models that work best. All of them start with understanding where the gaps are. How is the system functioning now, current status, and what future direction might the program take? That's the focused on the context, the environment, the problem, the challenges. But part of that is understanding what's going on in your curriculum now, and we often refer to that as curriculum mapping. And that's often a really critical step, simply because many of the components within our educational systems do not talk to each other. And so the role of a developer in this setting is to map the whole curriculum, see where the gaps are, and understand what is needed. Now, the process that Patton has developed is called developmental evaluation. And it assists innovators to develop social change initiatives in complex and uncertain environments. And let's face it, most of our change initiatives are in complex and uncertain environments because they involve people and communities and learners. The key is that it facilitates real-time feedback to the program staff and therefore facilitates continuous development. There's a couple of references there, but it's basically the work of Michael Patton. The developmental evaluation emphasizes the social mission of the education institution. Are the needs and priorities of the people, and I'm sort of using that as a way to say either neighborhood, region, community, society, all those words are relevant. Are they being met? And are the people or the community or the neighborhood involved in the evaluation process? That's a somewhat new concept in this developmental evaluation realm. Its focus is on the future. Its focus is on continuously improving the innovation. And it's currently being used at the Northern Ontario School of Medicine. They have a project called Social Accountability as the Framework for Engagement for Health Institutions. I don't believe they've published anything yet. I did a recent search and didn't see anything, but I suspect there'll be something coming out shortly. Now, the questions that a developmental evaluation process might ask include, how well is the health institution keeping you, that is to say, the people in the community, you and your community well? How well do our students engage with your community? How effective are we in preventive care? How effective are we in curative care? How well do our students adapt to new challenges? How well is the health institution collaborating with other sectors to address structural issues that affect our health or your health? And then finally, where can we do better? So you see how these questions are forward-looking, they're engaging community, and as you might guess, they often involve qualitative data. So that's a challenge that I'll address in a moment. The guiding principles are that innovation and evaluation are developed together, and the developmental evaluation becomes part of the change process. Its focus is illustrating how the change is new or novel, or how it's adapting or modifying traditional thinking into new contexts. It's also a systems-oriented process where it focuses on interrelationships and engages with contrasting perspectives. It recognizes that situations are often uncertain, emergent, dynamic, and the evaluation is responsive to this reality and has the capacity to shift as those realities change. And it is utilization focused. So it pays attention to the intended use by intended users from the beginning, and it ensures utility and actual use of this evaluation system. The focus is not just on collecting data and seeing whether you've met the mark. The focus is on continuously gathering data, feeding it back to participants, feeding it back to the main actors with the intention of generating continuous improvement. And here the feedback needs to be timely, and it has evaluation rigor, asking probing questions, questioning assumptions, applying evaluation logic, using appropriate methods, which are often qualitative, and staying empirically grounded. That is, this is all about gathering evidence. The sort of contrast or comparison between traditional evaluation and developmental evaluation. In purpose, a traditional evaluation supports improvement through summative tests and accountability. The developmental evaluation supports the development of innovation and adaptation in a changing environment. The roles in traditional evaluation are positioned where the evaluator is positioned as an outsider with the intent to ensure independence and objectivity. In developmental evaluation, the evaluators are positioned as internal actors, where the team gathers, interprets data, frames issues, raises and tests model issues. The accountability in a traditional program is focused on external authorities and funders based on explicit and preordained or preordinate criteria. That's very appealing to our traditional stakeholders, whereas the accountability for developmental evaluation is centered on the values of the innovators and their commitment to make a difference. In traditional evaluation, we're using traditional research and quality standards. In developmental evaluation, the methods are selected to serve a developmental intent. In traditional, the measures of success are set against predetermined goals and SMART outcomes, similar to the learner outcomes. These are, again, very specific and measured outcomes. Whereas in developmental evaluation, develops measures and tracking as the outcomes emerge, and measures can change as the process unfolds. The evaluation results in a traditional process or in a sort of formal report. In a developmental evaluation, they are rapid, real-time, user-friendly, with the intent to nurture learning. And finally, in traditional evaluation, we don't like uncertainty. We want to gain control of the design process. In developmental evaluation, we recognize that there may be a lack of control, and we learn to live with that, and we stay in touch with the contextual changes and respond accordingly. The standards for traditional evaluation adhere to standard methods, credibility with external funders and authorities, and analytic and critical thinking. In developmental evaluation, the standards remain flexible. They're adaptable methods. It focuses on systems thinking with a high tolerance for ambiguity, teamwork, and people skills. And this is where some of the aspects of the qualitative data that we generate comes to play. So the developmental evaluation process has a need for interviews, focus groups, collected stories, and qualitative analysis with a rapid turnaround to improve the process. Interestingly, whereas it takes a bit of convincing for stakeholders to embrace this process, often it is the community that is the most vocal proponent of the evaluation process, and the empiric evidence frequently comes from those community voices. That was certainly or has been the experience from the Northern Ontario School of Medicine when they presented this topic recently. The process avoids that common pitfall of evaluation, which is that we often count what we can count. Unfortunately, what we can count often doesn't count. So we're looking for the keys under the light post because that's where the light is. Now, we're not necessarily getting into the complex, challenging, sometimes messy issues of what the impact of our health workforce education process is on wellness and health. Now, we're certainly going to be combining various elements, and we still need to focus our understanding of the change in knowledge behavior. We need to understand impact, avoiding that Kirkpatrick level 1 element of evaluation, which we so often see, and I suspect it's the most common thing in the literature. Did they like it? It's nice if they like it, but it's really not going to make the difference in when we ask that question, are we meeting the needs of our constituents? And then, of course, there are other helpful domains. We need to understand output issues, how things you can count. I often call them number of students, number of sessions, understanding the process, how much did it cost, faculty training, and then understanding whatever the innovation is, not just did it work, but why did it work? So those elements are important to combine, and it's important to combine the various processes, whether it's the SIP process, whether it's Kirkpatrick, whether it's Kern or Patton, into a program that's forward-looking and gives rapid turnaround. So in summary, the fundamentals of education are fundamental. We need to align objectives, methods, assessment, and a blend of evaluation methods may be best. Process-oriented through SIP, results-oriented through Kirkpatrick, Kern in terms of implementation, and Patton in terms of development. So consider a developmental evaluation process that supports innovation, implementation, and continuous improvement that may be co-created with participants, whether that's students or community, that has fast, easy-to-use feedback and results in rich, qualitative data that can guide the path forward for improvement. Thank you very much, and I look forward to your questions.
Thank you, Bill, for wonderful presentations, and it is always nice to listen to you. And things have been clarified in a easy way. Whenever we are planning the evaluation, we need to keep the things in mind, whether the objectives are smart or not, whether the assessment has got the validity, and whether the learning environment has been full of enthusiasm or not. During the assessment and evaluation of the program, we need to determine whether the changes in the knowledge, skill, attitude, behavior of the stakeholders have been achieved as per the expectations, or there are gaps. And if there are gaps, can they give us direction to move forward and bring out necessary changes? I think methods which you have prescribed, use of interviews, focus group discussion, narrative qualitative analysis. And I think once we apply these principles, we will definitely move forward and bring out necessary changes and corrections in our curriculum. And
anybody has any questions, I think you can pass on to us. We will forward it to Bill, and I'm sure we'll get the answers. Thank you so much.
Thank you, sir. Now we proceed for the valedictory NCHPE 2021. We are truly delighted to extend a warm welcome to the valedictory ceremony of 12th NCHPE 2021. I'd like to extend a very warm welcome to the distinguished guests, esteemed panelists, and esteemed delegates. During the 5 days conference, we all have shared our experiences, best practices to deal with the menace effectively, and also discuss various ways and means to sharpen our attack on improving the education system through keynotes, designing CBME curriculum, student-doctor method of training, integration and practice, preparing the students for CBME, and how to teach the people effectively deal with the operation that is theater of oppressed. The panelists, delegates have also discussions on 2-year journey through the CBME ways, structuring the timetable, hindering or facilitating expert subjective judgment in CBME. We acknowledge the active participation and involvement of faculty, student, and staff of our institute that has made this event more vibrant, colorful, and successful. Despite our continuous efforts, there might have been minor lapses. I hope you forget those unintentional lapses and carry home the good and the sweet memories. Now we begin with the closing ceremony of NCHPE. I invite on SGRDUHS, Dr. Vivek Arvind Sauji, and Dr. Avinash Subbe, and Dr. Tajinder Singh to lead the celebration. So kindly give a token of appreciation to the faculty involved in the organizing NCHPE 2021. Dr. Meenakshi Gupta, Dr. Richa K. Haman, Dr. Punita Salwan, Dr. Manmeet Kaur Gill, Dr. Monica, Malhotra, Dr. Dimple. Dr. Seema. Dr. Chiranjeev. Dr. Harpreet Kaur. Ms. Sukhjeet Kaur. Dr. Neha. Dr. Navneet Sood.
What happened? What happened, Bache? Come here. What everything? You're the one who has done everything from beginning till the end. What happened? नहीं कुछ नहीं हमें. Rosha, the everything.
Come, my God.
Everything the son knows. I think every day only these two were the ones who started. नहीं ऐसे बात नहीं है. And then everything.
Dr. Sukhjinder. Dr. Amarjeet Kaur, Dr. Anju. Dr. Kanika. Dr. Navneet Sood is there. Harpreet Kaur. Navpreet Kaur.
Very well, smiling always.
A token of appreciation to the students involved in organizing NCHPE 2021. Ishan, Tanrajveer Singh, Ramash Singh, Devin Benedict, Sachin, Kamal Singh, Samriti Kaur, Sharanpreet Kaur, Ranvinder Kaur, Prab Simran Kaur, Anurag Kaur, Harmoon Kaur, Amarjot Singh, Puneet Kaur, Jashanpreet Kaur, Manjot
Just exchange your names and names. नाम देख लेना.
certificate of
म्यूजिक की रिकॉर्डिंग अविनाश बहुत अच्छा है she was really asking for कल वाले शब्द है तेरे पास दे देना सर
We also request the dignitaries to present abstract book to the students involved and participated in the.
And actually, they are the first year MBBS students who have submitted their posters in this NCHPE 2021 MBBS first prop, and they were guided by the faculty. And they want to accept their abstract books.
Narinder Kaur, Simran Kaur, Anjit Kaur, Sunil Kaur, Jasmine Kaur, Mehak Khanna, Shivangi Sehgal, Jaganveer Kaur, Ashmi.
एक पोस्टर वाला जाएगा
बेटा आ जाओ ना कबीर मैदान सहजनूर सिंह जसमीत कौर गुरमेहर सुमेहर सोडी रघुवीर कौर मनदीप कौर अमनदीप कौर आकर्षण मनदीप कौर जोया कार्तिक रोहित मल्होत्रा अमनप्रीत कौर ईशा गोयल सुखजीत कौर अनमोलदीप कौर
So there is a special thanks to somebody who was not from our institution, and but she has been writing certificates from day one. Maybe she will be coming for one more week.
Token of appreciation to the college staff involved in NCHPE. Manohar Singh, Moore Singh, Lalit, Vijay, JP Singh, Dilbag Singh. Rajinder Singh, Jatinder Singh,
ललित
ललित को तो बोला, दिलबाग भी बोला, ललित भी बोला।
आपकी बारी में मैंने दोबारा बोलूं क्या? अजीत सिंह, हरिंदर सिंह, ललित कुमार।
अजीत सिंह नहीं आए। तो क्या बुलाओ सारा ने वो पीछे चले। Thomas, please receive your token of welcome. Kunvinder Singh, Kanwaljeet Bibi ji, Jarnail Singh ji.
Yeah, I think you missed these two people.
Saiba and
Is it there?
Now
we have to thank at least to the what if not anything else.
I have.
Good evening. I must personally express my thanks to all of you who worked really hard with sometimes very less support, but managed to put up a very decent and very nice show. As I read the messages that I am getting on the WhatsApp groups, every single person who has been here has been highly appreciative of your efforts. Thank you, program, the organization, food, stay, transport. I don't think there was anything where anybody could complain. In fact, once or twice I tried to remind Saiba that said vehicle for them, and she literally scolded me. आज तक कोई शिकायत मिली है तो मिलेगी. That is. So that was the objective assessment. A subjective assessment remains, and I think I should use that. And one person who we can't really thank enough is Sahiba.
The team effort. I want to say that. I just wanted to say it is a teamwork. And you can see that my team, everybody just said that, yes, Saiba, your team is very strong. I said, I learned from leadership that you have to throw your monkeys. But that doesn't really help if you don't have anybody to catch those monkeys. So I have the team to catch all those monkeys. So I was just continuously throwing my monkeys into their pockets and they were catching it. We are all like that. We are trained to do it and we are doing it. Thank you so much.
Arvind Singh and Narinder Singh to please receive a token of appreciation.
Thank you very much, everyone. Have a safe journey and enjoy the rest of the day.
Last
Photograph something.
Madam.
Photograph.
Photo.
And